So hi guys, I hope I'm audible and visible to you. Okay, yeah. So just give me, just drop like a thumbs up in the comment box or something like that, right? Yeah. Good evening, Rishabh. Good evening, Satya. Okay, and I'm really sorry, guys. I'll share the PPT of the annotated video of yesterday's session and today's session after today's session ends. Okay, so I'll put it in the group. Yeah, I'll definitely do that. I'm really sorry I was not able to kind of do it today. Okay, right. So let's kind of start. Shall we start? I think we should start, right? Okay. So first of all, let me know the voice is okay, or should I increase it or something like that? I'm using a different mic today. I noticed that there was a bit of more hissing in the yesterday's sound, so I'm using it a bit different mic. I hope it's audible clearly. Yep. I hope it's audible clearly, right? Okay. Right. Okay, just a minute. We'll be starting. Okay. Right. Okay. Right. So yeah, let's kind of start. Good evening. Right. Okay, guys. So today what we are going to do is we are going to first quickly cover the hepatobiliary pancreatic system, and then we'll be talking about the urology and the urological trauma. That's what we are going to cover in the today's session. Okay, that's what we are going to cover. So let's start with the liver abscess. Okay, so liver abscess, predominantly what you need to understand, what we have is we have something which is called as a pyogenic liver abscess and the amoebic liver abscess. Okay, so which is what you call as yeah. So which of this is what you refer to as just give me a minute here. Okay, so what are we going to talk about? We are basically going to talk about the pyogenic and the amoebic liver abscess. Now, what you need to understand is, if I ask you, what is the most common route of spread of this pyogenic liver abscess? Okay, so let's start with the pyogenic liver abscess. What is the most common route of spread of the pyogenic liver abscess? Is it like an ascending infection from the biliary tree? Is it like the hematogenous spread, or is it like the direct inoculation into the liver or something like that? So what is the most common route of the spread of this particular pyogenic liver abscess? The answer to that particular stuff is what you refer to ascending infection. Okay, so please do remember it's a simple one-liner, but this has been asked a couple of times. Okay. Right, so now let's kind of gather the speed over here. Okay, so pyogenic liver abscess. First of all, what on earth is this particular pyogenic liver abscess? Pyogenic liver abscess is basically a condition where there is a bacterial infection. So pyogenic means bacteria, so there is a bacterial infection into the liver. Now, if at all there is a bacterial infection which is happening into the liver, it has to kind of spread to the liver in one form or the other, right? So the most common route of the spread is this. Okay, so ascending infection via the biliary tree. So what happens is there is some kind of a biliary obstruction, let's say a stricture or stone or something like that, and then there is an ascending cholangitis which is leading to the abscess, which is like the infection which is leading to the liver, and ultimately there is the formation of a pyogenic liver abscess. Now, if at all we would have been having this particular discussion, let's say 20, 30, 40 years, like 30, 40, 50 years back, then probably the answer would have been the blood spread. So from where? So from, let's say, the conditions like the appendicitis or the diverticulitis or something like that. Why? Because what you need to understand is that the infection can spread via the portal vein into the liver, right? But in today's time, we have a good like a good number of antibiotics, and people are bit vigilant, and the antibiotics are given in the like the start of the disease itself. So the chances of the spread of the infection via the hematogenous route is significantly less. Okay, so that's what you need to understand. The chances of spread via the hematogenous route is significantly less. So this is important, okay, right? So also portal vein is involved in this, okay? So yeah, that's what Satya is saying. But please always remember that this is the second most common cause. It is not the first most common cause of that, okay? Now, obviously, how will the patients present to you? The fever, like the pain in the right hypochondriac, then fever and the rigors and the chills and all those particular stuff. What we are dealing with is a pyogenic. So there is a pus, obviously. So all these particular things will be there. Now, the important things in the labs is, okay, obviously the TLC and everything will be elevated. That's all fine. But the one thing which you need to understand is this alkaline phosphatase. So what does this alkaline phosphatase tell you? It basically tells you that there is some kind of a biliary obstruction. So this is basically elevated in around 25% of the patients, not in every individual, but around 25% of the patients, what you basically have is an alkaline phosphatase is elevated. Okay, I hope you have understood this point. Now, on the diagnosis, what you need to understand, ultrasound can be done, CT scan can be done, all those particular things can be done. So if I simply ask you, what is the investigation of choice to diagnose the pyogenic liver abscess? Do not mark it as an ultrasound or a CT scan or something like that. You have to kind of aspirate and you have to kind of send it for the culture. If at all somebody asks you radiological investigation of choice, then the answer is going to be the kind of a CT scan. So radiological medical investigation of choice, then the answer is going to be a CT scan, contrast and a CT scan. Okay, but overall, what is the investigation of choice? It is basically aspiration of that particular abscess and the culture. You have to kind of have the organism in front of you, right? Now, what about the management? So there are two things. Okay, so what you can do is either you can just put in a whatever the catheter, you can kind of aspirate whatever the abscess and you can kind of throw it off, right? That's what you can do. But what you need to understand is that it is not like that's not going to kind of treat it completely. So what you have to do is you have to put in a drain. So if at all they give you two options, ultrasound guided aspiration versus ultrasound guided drain insertion. So drain insertion is the kind of answer because the abscess is not always kind of liquid. So 30-40% of that is in the solid form and it's going to kind of continue to drain for, let's say, 3-4-5 days or something like that. Are you understanding my point? So once the drain output is very less than 20-30 or so, then you kind of remove that particular drain. I hope you have understood, and obviously you will start the kind of antibiotics. Yes, definitely. Right. So yeah, if at all they ask you the initial, obviously you are going to do an ultrasound because the patient is going to come to you with the pain and everything. But the ultrasound is not kind of very diagnostic because ultrasound will not be able to tell you whether it is an amoebic, pyogenic, and all those particular stuff. Ultrasound is definitely not diagnostic. Okay, so please do understand, investigation of choice overall is definitely aspiration of the abscess along with the culture. Now you can just remember the most common organism overall is E. coli, and in the Asian countries it's Klebsiella. Forget about it. Just remember the most common organism overall is E. coli. So do not forget this particular point. Okay. Now coming to the amoebic liver abscess. So how does this particular amoebic liver abscess basically forms? Amoebic liver abscess is basically formed because of the Entamoeba histolytica. And how does the infection basically spreads? By the fecal-oral route. So contaminated food and the water and all those particular stuff, right? Now, what is an infective stage of the amoebic liver abscess? What is the infective stage? So the infective stage which you basically have in the amoebic liver abscess is the quadrinucleate cyst. Please remember this. This is what is your infective stage. Important question. Infective stage. So what happens is that you like whatever the patient basically drinks, whatever food, pani puri, whatever you guys have, and then this particular quadrinucleate cyst basically reaches to the intestine. But which part of the intestine does this particular kind of things kind of release the trophozoites? So please remember, predominant part of the intestine which is basically affected is the cecum and the ascending colon. It has been asked a couple of times. So cecum and the ascending colon is the part which is basically affected. Now what happens in this particular cecum and the ascending colon? Here there is a formation of a flask shaped ulcer. So flask shaped ulcers are basically formed, and in this particular flask shaped ulcers there are the trophozoites. These particular trophozoites are going to enter into the bloodstream like the portal vein, and they are basically going to go to the liver, and in the liver they are going to cause the enzymatic degeneration where they're going to kind of lead to a dead and the shriveled hepatocytes and everything, and ultimately leading to an amoebic liver abscess. Are you understanding my point? So very important, this particular pathogenesis of the amoebic liver abscess is very important. Okay, I hope everybody have understood this particular point. Yeah, this amoebic liver abscess appears like an anchovy sauce bus. So if what about the clinical features? Obviously there's going to be the patients who are going to have pain. Occasionally you can have fever as well. All those particular things are fine. Ultrasound. Okay, so if I ask you what is an investigation of choice to diagnose the amoebic liver abscess, I want you to answer it in the comment box. Okay, so what is the investigation of choice in order to diagnose an amoebic liver abscess? What is the answer? ELISA. Yes, absolutely right. Okay, please do not mark it as an aspirational culture. It is serology. Okay, ELISA. ELISA is the investigation of choice for the kind of diagnosis. But if they ask you radiological investigation of choice, then you can answer it as a contrast and a CT scan. Okay, so I hope you have understood this point. Okay, right. Now, what about the kind of treatment of choice? Like, how do you manage these particular patients? Is it like a drainage? No, not really. Okay, so the management is basically what you refer to as by the medication. So metronidazole 750 milligrams 10 to 14 days. So in Sebastian they have written kind of 10 days, that's fine. So metronidazole 750 milligram 3 times a day for 10 days. That's what you basically give in the management of this particular stuff. Okay, now will you ever kind of drain this particular stuff, or rather will you ever aspirate this particular amoebic liver abscess? The answer is yes. So what are the conditions where you're going to kind of aspirate this? No improvement in 3 to 5 days. You've already started the metronidazole, but the patients are not improving. Already 3 to 5 days have happened, but the patients are not improving. High risk of the rupture. So when is the high risk of rupture going to be? If at all, this is very important. Okay, do not forget this. If at all the size of the abscess given is more than 5 centimeters, or if that particular abscess is involving the left lobe of the liver. So okay, so size more than what you call as a 5 centimeter, and like left lobe of the liver. Okay, so that's what you need to understand. Then diagnostic uncertainty. It means that you're not able to decide whether it is amoebic liver abscess, pyogenic liver abscess, what or not it is. Bacterial superinfection. So sometimes bacteria can superinfect on these particular amoebic liver abscess. That is one of the indications of aspiration. And pregnancy. So high dose metronidazole is not safe in the pregnancy. Now they have kind of put in the dicey category, whether it's not safe, it's not unsafe, blah, blah, blah. They keep on fighting over this. But what you need to understand is in the pregnancy, you avoid this, and there again, you'll have to kind of aspirate it. Okay. So I hope you have understood this point. Now, then forget about this intraluminal agent. So metronidazole, basically it's only acting in the whatever the intestine or something. They're basically going to take care of the trophocytes in the liver and everything. But the intraluminal agents are basically here parabomyxin and the idoxyquinolone and the diloxamide. All these particular things are the intraluminal agents. So they are basically going to prevent the recurrence of that. Okay. Now, if we talk about the complications, so what is the most common site of the rupture? If we talk about the pyogenic liver abscess or the amoebic liver abscess, please remember the most common site of the rupture is the peritoneum. In the exam, do not mark it as a thorax. Okay, thorax, yes, rupture can happen, but that is not the most common site of the rupture. The most common site of the rupture is inside the peritoneum. Okay, I hope you have understood this particular point. Very, 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 very important. Okay, so the most common site of the rupture is your peritoneum. Understood? Right. Now let's talk about the hydatid cyst. So what is the causative organism of this particular hydatid cyst? It is basically Echinococcus granulosus. Okay, so what is a definitive host of this particular Echinococcus granulosus? So definitive host is the dog. The intermediate host is basically the sheep. So man is what? Man is basically an accidental host. Okay, so man is an accidental host. Okay, so I hope you are able to understand this particular point. Okay, right. So Satyaja, I hope you have understood. The most common site of the rupture is not the pleural cavity. Okay, so please remember it is the peritoneal cavity. So please remember that. Very, very important. Okay, right. Okay, now coming back to the hydrated cyst. Okay, so man is an accidental host, blah blah blah. Yeah, that's all fine. Okay, now the fecal route, what happens? This hexacanth larva is basically released into the intestine and everything. It somehow reaches the kind of the liver, and there it basically leads to the formation of a kind of a hydrated cyst. Okay, so most common organ involved is liver, obviously, because the portal vein, like the blood from the portal vein, basically predominantly goes to the liver. That's all fine. Clinical features usually asymptomatic. The usually in the history they are going to give you the farmer, which the history of whatever the lot of contact with the dogs and the sheep and everything, and they are going to have an asymptomatic lump on the right hypochondriac region. That's what they're going to have. Okay, now if you talk about what you call as an diagnosis, okay, so please remember this. Again, the investigation of choice over here is a serology, that is ELISA. On the ELISA, what are you going to find is this ARC5, characteristic ARC5 appearance, which you're basically going to find on this particular ELISA. Very, very important. Okay, right. So there are other things as well. So this also sounds very, very attractive to the students. Many students mark it as a Casone's test. What is this particular Casone's test? So inside the hydrated cyst, you have a hydrated fluid. This hydrated fluid is highly immunogenic. Okay, so what you can do is, if at all you kind of put this particular hydrated fluid intradermally, what happens? There is a wheel reaction which basically takes place. And that is what is going to kind of, it's like a tuberculin test. Okay, it's something similar to that, but obviously that is not very, very sensitive or specific or something like that. And yeah, that's practically not done because there is a risk of anaphylaxis taking place, because that's an highly immunogenic kind of a substance. So please remember, what is an investigation of choice? So investigation of choice is serology, that is ELISA, that is ARC5. Okay, now if I again ask you the radiological investigation of choice, what is going to be the radiological investigation of choice? The radiological investigation of choice is going to be the CECT. So please try to understand. Once they had asked you a question and they had asked you what is the investigation of choice, they did not mention radiological or anything like that. They just ask you the investigation of choice. And the investigation of choice, they asked you the X-ray, ultrasound, whatever, the CT scan, and they gave something else. Okay, so then the answer was the CT scan, because they did not give you ELISA in the option. I hope you are able to understand this particular point. Okay, now again, Satya, please try to understand, it is not the ultrasound, it is the contrast, it's the contrast in a CT scan. That is what is an radiological investigation of choice in order to kind of diagnose what you call as a hydrated cyst. Okay, understood? Now, what about the management of this? So the management of this is basically pair. What is this particular pair? Pair basically is your puncture, aspiration, injection, and then reaspiration. Do I have the image? I don't. Okay, so what is this particular puncture? So obviously you're going to puncture this particular hydrated cyst. You're going to aspirate the content. So why you're going to aspirate the contents? Because inside this particular cyst you have a hydrated fluid which is highly immunogenic. Okay, so it's a highly immunogenic kind of a thing, and that is why you have to kind of completely aspirate it. Then you have to inject. What do you want to inject? You want to inject the scolicidal agent. And what is the most commonly used scolicidal agent which we have? hypertonic saline. 20% hypertonic saline is the most common homicide, like the scolicidal agent which we have. Okay, so we do understand the scolexes, the daughter cysts and everything, we have to kind of get rid of them. And then finally you have to reaspirate these particular contents. This is the pair. So pair technique is basically used in order to manage these particular stuff. What is the contraindications of the pair? So let's assume that you have an inaccessible kind of a cyst. So it's a very, very deep-seated cyst which is present near to some very, very vital structure, something like that. Again, it's going to be contraindicated. Periphery located cyst. So why periphery located cyst? Because there is a high risk of rupture in these particular stuff. Multiloculated cyst. You cannot kind of do this in the multiple cyst. Cysto-biliary communication. So if at all there is a communication between the biliary cyst and the bile duct. Okay, so that's what you need to understand. Cyst in the lungs and the brain. Okay, so forget about this, not that important, that's all fine. And calcified cyst. Why calcified cyst? Because calcified cysts are inactive cysts. Okay, so please remember these are the contraindications for the pair. Very, 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 very important. Okay, I hope you have understood this point. Okay, now the most common complication, forget about this, rupture of the biliary tree. Okay, now I'm pretty sure that you would have read about this particular stuff in your microbiology as well. So the 3 layers of this particular hydrated cyst. What are these particular things? So we have an endocyst, we have an ectocyst, we have a pericyst. So what is this particular pericyst? Pericyst is basically formed because of the compression of the surrounding structure. Okay, surrounding structure. What about this kind of ectocyst? Ectocyst is basically acellular. It is a hyaline layer. And what you need to understand, this endocyst is something which is the cellular. So this is what is going to kind of give you rise to these particular daughter cysts and everything. Okay, I'm pretty sure you would have read about these particular things in your microbiology. Just trying to kind of revise it for you guys. And as you were trying to say that there is something which is called as a Gerby classification. So the Gerby classification is like purely cystic and then your granulomatous membrane detached. So this is what is called as a water lily sign. Okay, so what is this? This is actually more important. We'll go back to that particular classification. So what is this particular sign? This is what is a water lily sign. Okay, what is this? This is a water lily sign which you can basically get in the ultrasound or the CT scan or something like that. What does this basically tells you? That the endocyst has basically detached from the ectocyst and the pericyst. Okay, so this is what is a ruptured hydrated cyst. Okay, intracapsular rupture of the hydrated cyst. Okay, so that is basically falling into your Gerby's type 2. Okay, so this is falling in the Gerby's type 2. Then the type 3 is basically the multicystic lesion separated by the septa, so that is a honeycomb appearance and all those particular stuff. Then we have a cyst which is degenerated in the pseudo kind of solid appearance, and the so like whatever the calcified cyst is basically the type 5. Now this is what is a Gerby's classification, but nowadays what you basically use is a WHO classification. Now the WHO classification and the Gerby's classification are more or less the similar. The only difference is over here. So WHO type 1 is the Gerby's type 1, that's all fine. Then what we have is a WHO type 2 is this multiloculated cyst. WHO type 3 is basically what you refer to as this. Like the water lily sign is basically present in the WHO type 3. Then we have this particular type 4, and the type 5 is basically the what you call as calcified cyst. Okay, so the calcified cyst is the type 5. So please to remember there is a Gerby's classification, there is a WHO classification. The only difference is that then 2 and 3. So please go through this. This is important. Okay, understood? Right. Now, water lily. Okay, water lily sign. Okay, so it's a water lily sign. It's not a water snake sign. Okay, right. Now let's talk about the liver tumors. In the liver tumors, what you basically have, you have a benign tumors, you have a malignant tumors. Okay, now which is the most common tumor of the liver overall? It is going to be the hemangioma. That is the most common tumor. That's fine. Then we have a like focal nodal hyperplasia, and then we have a hepatic adenoma. So as I told you, hemangioma is basically the most common. It's a benign, it's asymptomatic, all those particular things are fine. Now once they had asked you a question, what is an investigation of choice? Okay, so what is an investigation of choice for a hemangioma? What do you think? What is the answer? Please put it in the comment box. What is the investigation of choice for the hemangioma? It's a very unfair question to be asked, because the CT scan and MRI both are very good investigations in order to kind of diagnose the hemangioma. So it is not a Doppler. It is like the doubt was basically between the CT scan, contrast and CT scan, and the MRI. So what you need to understand, the answer is MRI. Please remember this, guys. Okay. Now again, like there's no book where this has been clearly written that you know what, MRI is the investigation of choice. But after going through a lot of literatures, what you need to understand is that they basically say that the MRI is the gold standard investigation to diagnose the hemangioma. But at the same time, they also tell that you know what, contrast and CT scan is very, very accurate in order to diagnose blah blah blah. But if at all I get this particular question, as I told you, it's an unfair question to be asked, but if at all they give you, you have to kind of mark it as an MRI. Okay, that's what I would have marked. Okay, I hope you have understood this point. Okay, now Light bulb appearance, you all must be knowing that. Again, I'm sorry, I don't have the image of that. So what is this particular light bulb appearance? Okay, so just Google, if at all you wish, just Google this particular hemangioma MRI, and what you're basically going to see is that there is going to be what you call as a hyper intense kind of a lesion. Okay, hyper intense lesion, and all the surrounding is basically going to be black. So what you need to understand in the T2 weighted MRI, rest all the surrounding is going to be black, but the hemangioma is going to light up. So that's what it's like, light bulb appearance. Okay, so that is what you need to understand. Obviously the FNAC biopsy is going to be the contraindicated because a lot of bleeding will start, and obviously that's the reason why it is contraindicated. Treatment is enucleation. Okay, so plain simple, enucleation. Enucleation is the treatment of choice for your hemangioma. Okay, forget about the Kasabach-Merit syndrome. That is what is a giant hemangioma. That is what is usually symptomatic. Let's not go there. Okay, so please try to understand. Investigation of choice for hemangioma is an MRI. Treatment is enucleation. What do you get on the MRI? Light bulb appearance. Okay, now focal nodal hyperplasia. Now this is the second most common. That's all fine. It is associated with the oral contraceptive pills, more common in the females. That's all fine. It's benign. It has no malignant potential. Focal nodal hyperplasia is not having any malignant potential. On the contrast, in a CT scan, what you basically get is a central stellate scar. Now, which is very important. Okay, so what you basically get on the whatever CT scan, you basically get a central stellate scar. On the angiography, what you basically get is a spoke wheel or the cartwheel appearance. Okay, on angiography, you get a spoke wheel or a cartwheel appearance. The management is basically observation. So that's all fine. That's what you need to understand over here. Now, the sulfur colloid scan. Sulfur colloid scan. What do you basically get in this particular sulfur colloid scan? You basically get a lighting up of the, okay, so there are the Kupffer cells which are basically present in these particular focal nodal hyperplasia, and on the sulfur colloid scan you are going to get a like a positive result. Okay, so that's what you can need to understand. Sulfur colloid scan can be used to diagnose the focal nodal hyperplasia. So what are the questions asked over here? CT scan can be asked, central stellate scar, angiography, spoke wheel, cartwheel appearance, completely a benign kind of a thing, completely asymptomatic. Sulfur colloid scan, it basically shows a hyper intense kind, like it shows a positive finding, and the treatment is not a surgery, it is just an observation. Now, in contrast to the focal nodal hyperplasia, when we talk about the hepatic adenoma, what is the basic difference? The basic difference is that, okay, so what is the similarity? The similarity is, even this is more common in the females, this is more associated with the oral contraceptive pills. Okay, so but what is more associated with the oral contraceptive pills? So it is the what you call as a hepatic adenoma. Hepatic adenoma is the one which is more associated with the oral contraceptive pill. Now, what are the problems with the hepatic adenoma? First of all, it is not asymptomatic. It is going to have some kind of a dull aching pain. Now, the major things with this is it can spontaneously rupture. So around 30 to 50% of the patients may have a spontaneous rupture. And if at all they spontaneously rupture, what is going to happen? A lot of bleeding is going to happen, exsanguination is going to happen, and the patients might become hemodynamically unstable. So that is again a major drawback of this. Then finally, the hepatic architecture is not maintained, all this particular thing is fine. And finally, what you need to understand, there is a risk of malignancy. Okay, so there is a risk of malignancy, and that is why if at all there is a patient who is basically having a hepatic adenoma, here you have to go ahead with an excision. But in the focal nodal hyperplasia, what did I tell you? That you have to just go ahead with an observation. Okay, so that is what you need to understand over here. Okay, so this is all what we are going to cover in the liver. Now, okay, so this just for the new students, if at all you guys are kind of watching this, if you wish to connect with me over the WhatsApp, you can scan this particular code, or I have my number in the kind of a description below. You can connect with me and for the questions or something, and I also have a small WhatsApp group. If you wish, I can add you to that. This is the YouTube channel which you're basically looking this particular video at. If you wish, please do kind of consider subscribing it. And this is basically the QR code for the Instagram. If at all you wish to kind of follow me there, I will be active on that pretty soon. Okay, so what we have talked about the liver. Now let's talk about here what you call as a gallbladder. Okay, everybody's okay with this? Any doubts in the liver? Right, so let's talk about the gallbladder. In the gallbladder, what you need to understand is, if you remember all the things which I have kind of written on this particular slide, then you will kind of revise the particular entire kind of gallbladder. So let's kind of start with that. So what about the so first of all is the gallstone. Okay, so the gallstone can happen. Okay, so where all these particular, let's first get familiarized with the terminologies. Okay, so what are these particular terminologies? What you need to understand, the gallstones can happen either in the gallbladder. What do we call it? We basically call it as a cholelithiasis. Cholelithiasis. Then these particular gallstones can kind of obstruct what you call as the neck of the gallbladder. Then what are we going to call it? We are going to call it as an acute cholecystitis. Or these particular gallstone can enter into the common bile duct over here, and then what we basically call it as a choledochal lithiasis. Okay, so just I'm pretty sure that you guys know, just for the revision purpose, Cholelithiasis, acute cholecystitis, choledocholithiasis. Okay, understood? Now, in the okay, so this is very, very important. So, yesterday we talked about the breast cyst, right? What did I tell you in the breast cyst? That you get a posterior acoustic enhancement. Now, I hope you are able to appreciate over here. What are you basically getting over here? You're basically getting the posterior acoustic shadowing. Are you understanding my point? So, what are you basically getting over here is the posterior acoustic shadowing. In the cyst, what you basically get is a posterior acoustic enhancement. So, what is an investigation of choice in order to diagnose whatever the gallstones? The investigation of choice is ultrasound. Please try to understand over here. The investigation of choice in order to diagnose the gallstones is ultrasound. It's not the HIDA scan, it is ultrasound. Okay, gallstone diagnosis, the investigation of choice, simple good old ultrasound. Okay, so this is what you basically kind of do that, right? Okay, understood? Right. Now, the another important thing which you need to remember, that's all fine if all the patients are symptomatic. I hope you remember all those particular stuff, right? So, colic abdominal pain, Murphy sign, like Murphy sign is going to be there in the acute cholecystitis. But yeah, the colic abdominal pain and the dyspepsia and all those particular stuff, let's not go there. Just remember what is the indication of doing a cholecystectomy. Okay, what is the indication of doing rather the prophylactic cholecystectomy? So, this is very, very important. Okay, very, very important. So, okay, what are the indications of doing a prophylactic cholecystectomy? So, indications of doing a prophylactic cholecystectomy are, if at all, what should be the size of this particular gallstone in order to kind of remove it? More than 2.5 centimeters. Please remember this, very, very important. Okay, if at all the gallstone size is more than 2.5 centimeters, then what you need to understand is then you have to kind of remove that particular gallstone. Okay, then we have to kind of remove the gallbladder, not the gallstone. Okay, then what else? What are the prophylactic indications of removing a kind of a gallbladder? Porcelain gallbladder. Okay, porcelain gallbladder. What do you understand by the porcelain gallbladder? Calcified wall of the gallbladder. That is what is called as the porcelain gallbladder. Or if at all you have a gallstone in association with the polyp. Okay, so if at all you have a stone plus the polyp, then again it becomes a prophylactic indication to kind of remove that particular gallbladder. What else? If at all the patient is basically having a hematological disorder, sickle cell anemia, hereditary spherocytosis, because in these particular patients, the patients will have a recurrent formation of your pigmented gallstone. So all these particular things are the indications of removing a like prophylactic cholecystectomy. So let me just take a couple of questions from the kind of chat box. No shadow in the polyp, absolutely right. Okay, so in the stone, what you basically get is a shadowing. In the in the polyp also you may have a shadow. That's all fine. You may have a shadow in the polyp as well. Okay, you may have that. But what you need to understand is in the polyp, it is not going to kind of change the locations. Okay, it is not going to change the location. And if at all you have a what you call as a Doppler study, okay, so you have an ultrasound, you can quickly on the Doppler. Now in the stone, the blood flow to this particular part is not going to be there. But if at all there is a polyp, the polyp will have the blood flow. Are you understand my point? So the way to kind of distinguish the stone from the polyp is that okay, so polyp will have this shadow as I just told you. Now how do you kind of distinguish the two? So the way to kind of distinguish the two is that you can do a Doppler. So with the Doppler in the polyp, the blood flow will be there, and in the stone, what you need to understand, no blood flow. And if at all you ask the patients to kind of move, the stone will change its position, the polyp will not change the position. Okay, now gold standard is not the HIDA scan. Okay, so I hope you are able to understand this particular point, guys. Okay, in order to diagnose the gallstone, simple gallstone, the investigation of choice is ultrasound. Okay, I'll talk to you about the HIDA scan. I think that you guys do not understand the HIDA scan, what exactly it is. I'll kind of talk about this. Right. Okay, understood? Right. Okay, right. So this is all about the gallbladder stone which I wish to talk to you about. So this is kind of done. Now, as I told you that if at all this particular gallstone basically goes and kind of obstructs whatever the neck of the gallbladder, then what do we say? That the patient is basically having an acute cholecystitis. So what happens is that the gallstone is basically obstructing that particular gallbladder. So the bile is not able to kind of go out, and there's going to be an infection, and there's going to be a pericholecystic collection. So the fluid will get accumulated surrounding this particular gallbladder. So pericholecystic collection is going to be there. Are you understand my point? So that is what is a characteristic feature of your acute cholecystitis. Okay. Now, when we talk about the acute cholecystitis, okay, so I do not have a lot of slides over here. I'll just talk over here. Okay. Now, in the acute cholecystitis, what is going to be the presentation? So the colic abdominal pain, that's fine. But over here, the patients are going to have a high-grade fever and the leukocytosis and all this particular stuff. Simply in the cholelithiasis, you will not have the high-grade fever and the cholelithiasis or something like that. But in the acute cholecystitis, you're going to have the patients with the pain which is lasting for, let's say, 24, 36, 48 hours. And then the patients are going to have what you call it, the leukocytosis and the high-grade fever and all this particular stuff, right? There's going to be a characteristic Murphy sign where you kind of compress on this and the patient catches breath. All those particular things you would have read, right? Now, if I ask you what is an investigation of choice to diagnose the acute cholecystitis, can you please help me with this? Okay, HIDA scan, right? Yep. No. The answer is ultrasound. Okay, please try to understand. Investigation of choice is an ultrasound. So even the studies have kind of shown that the CT scan and the ultrasound, they basically give you the kind of similar kind of information. So ultrasound is considered to be the investigation of choice in order to kind of diagnose the acute cholecystitis. Just 1 minute. Okay, so what you need to understand is that what is a HIDA scan? So it is basically like an IVP. What you basically do is you put in a dye through the blood and that particular dye is taken up by the liver. Now this particular liver is going to excrete the dye. So once the liver excretes the dye, what is going to happen? The dye is basically going to go into the right and the left hepatic duct, common hepatic duct. It might enter into the gallbladder also as well, and then it is going to kind of through the common bile duct, it is going to go into the intestine, right? Are you understand my point? But let's assume that there is a patient who is having an acute cholecystitis. Will the dye enter into the gallbladder? No. So if at all there is a non-visualization of the gallbladder, then it is kind of considered that the patients might be having an acute cholecystitis or something like that. Are you understand my point? So yes, in the acute cholecystitis, HIDA scan can be done. On the HIDA scan, what is going to be the finding? Non-visualization of the gallbladder. But that is not the investigation of choice. Investigation of choice is what you call as the ultrasound. Okay, everybody have understood this particular point, right? Now, okay. Now, if at all there is a patient, so okay, there is a Tokyo classification which is associated with an acute cholecystitis, and that is something which you should kind of know. And yeah, that's just remember that. And what about the management? So, if at all there is a patient with an acute cholecystitis, and if at all the patient has presented to you early, then you have to perform an emergency cholecystectomy. But let's assume that the patients have come, let's say, after 4 to 5 days or 7 days or so, then you will have to perform an interval cholecystectomy. You understand my point? Acute presentation, emergency cholecystectomy. Delayed presentation, you have to perform what you call as a interval cholecystectomy. Understood? Now, if at all there is a patient with an acute cholecystitis, it can complicate into few things. What are the things it may complicate into? It may complicate into what you refer to as your empyema of the gallbladder. What do you understand by an empyema? That is a gallbladder which is filled with what you call as a pus. That is what is an empyema, pyocene, one and the same thing. Okay. Or more importantly, it can transform into an emphysematous cholecystitis. What is this emphysematous cholecystitis? In the emphysematous cholecystitis, there is a infection with the gas-producing organism, so Clostridium. And because of this important, most common organism associated with an emphysematous cholecystitis, Clostridium. Okay, Clostridium. Okay, right? Okay. Just give me a minute. Okay, right. So understood. So what you call as a Clostridium is the what you call like the organism which is most commonly associated with an emphysematous cholecystitis. Okay, I hope you're able to understand this point. Now, what else you need to understand over here? That the patients. Okay, so if at all there is a patient with an emphysematous cholecystitis, what is the emergency management which you're going to do? So what you're going to do is you're going to do a tube cholecystostomy. You're going to kind of put a tube and you're going to drain that particular bile from that particular gallbladder. Are you understand my point? So tube cholecystostomy, that is what you're going to do. Now, sometimes occasionally they can also give you a scenario where there can be an acalculous cholecystitis. What do you understand by an acalculous cholecystitis? Acalculous cholecystitis means that there is no gallstone, but the patients are having signs and symptoms which are very much similar to that of an acute cholecystitis. Now, when this is going to be there, so in the scenario, they are going to give you that the patient is admitted in the ICU, the patient is comorbid, and now you have been kind of called, and the patient has been admitted for the ICU for let's say 10-15 days or so, and now the patient is basically complaining of the pain in the right upper quadrant and everything. When you examine, everything basically goes in the favor of your acute cholecystitis, but when you do an ultrasound, there's no gallbladder. Like there's no gallbladder stone or any no stone which is obstructing the neck of the gallbladder. Are you understand my point? So in this particular scenario, you diagnose it as an acalculous cholecystitis, and over here also the management is going to be a tube cholecystostomy and an emergency cholecystectomy as well. But usually the patients are not fit to undergo surgery. So in the scenario, they're going to give you that multiple comorbid, uncontrolled diabetes mellitus, and ICU patients and all everything. So here you'll have to perform a tube cholecystostomy. So in the acute cholecystitis or an emphysematous cholecystitis, if the patient is fit, then you go ahead with an emergency cholecystectomy. Now let me just take a couple of questions. So, say in the MCQ, gold standard goes for HIDA scan. So please try to understand there's something which is called the gold standard. Okay, so yesterday we saw that in the breast lump, okay, in the breast lump, what you refer to as a gold standard investigation is your excision. Okay, so biopsy, that is the best kind of test. But do we do that in every kind of patient? No. What we go ahead with a true cut biopsy. So investigation of choice is going to be an ultrasound. If they specifically ask, gold standard investigation or something, then you can mark it as a HIDA scan. Okay, I hope you have understood this point. Okay, got it? But the investigation of choice in the routine practice, what you basically follow is an ultrasound. So HIDA scan is basically overkill. It can, like, we can kind of diagnose it with a simple ultrasound as well. So that is what you need to understand. Okay, got it? Right. Now, we have talked about all these things. Now, let's talk about these two terminologies, which are very, very important. So, there's something which is called as a Mirizi syndrome, and there's something which is called as a gallstone ileus. So, what is a Mirizi syndrome? Okay, so can you please help me with this? What is a Mirizi syndrome? So, if I tell you that, there's a patient who is basically having an obstructive jaundice. Okay, so if I say that there is a patient who is having an obstructive jaundice, what will you tell me? That what is the position of the gallstone in this particular patient? If at all the patient is having an obstructive jaundice, what is the position of the gallstone? So you would say that the position of the gallstone, gallstone, is in the common bile duct. Are you understand my point? But if I tell you that there is a patient who is basically having a obstructive jaundice, but the stone is not present in the bile duct, it is basically present in the gallbladder or the bladder neck or the bladder neck. Are you understand my point? So the stone is basically present inside in the gallbladder itself or in the bladder neck or something like that. I understand my point. So this is what is a condition which is referred to as a Mirizi syndrome. So there's something which is called as the Hartmann's pouch that basically leads to the obstruction of that, and there's in whatever the inflammation and because of all those particular stuff, the common bile duct is basically obstructed. Okay, I hope you're able to understand this point. Now, there are various types of the Mirizi syndrome. So what you need to understand is the fistula formation can take place less than 1/3, 1/3 to 2/3, more than 2/3. So there can be a fistulous communication as well. Based on that, you have 1, 2, and 3. So please try to understand this is what is the classification of the Mirizi syndrome. What is the management? You have to kind of perform a cholecystectomy. Sometimes you are not able to kind of remove the entire gallbladder. Then the partial cholecystectomy is done, but you have to ensure that you are basically, forget about this. Okay, so cholecystectomy is the management of a Mirizi syndrome. I hope you have understood this particular point. So did you understand the classification? If at all the fistulous communication is involving less than 1/3 of the circumference, 1/3 to 2/3 of the circumference, more than 2/3 of the circumference, 1, 2, and 3. Okay, now the next very, very important topic is gallstone ileus. Now, what on earth is this particular gallstone ileus? Let's assume that this is a gallbladder. So what you need to understand is that there is a gallbladder stone over here. Okay, now what can happen is occasionally this particular stone can erode through this particular wall of the gallbladder and enter into the intestine, and this can lead to something which is called as a gallstone ileus. So what is the name of the triad? Yes, very good. So it is what is called as a Rigler's triad. Very, very important. Okay, oh, very, very important over here. Never forget about this. Okay, so Rigler's triad is basically seen in the gallstone ileus. So what is this particular Rigler's triad? So here the patient is basically having the features of intestinal obstruction. There is pneumobilia. Okay, not hemobilia, it is a pneumobilia. Air is going into the gallbladder, right? So inside the intestine, what do we have? We have air, and this particular air can enter into the gallbladder. That is what is called as a pneumobilia, air going into the gallbladder, right? So ectopic gallstone. So gallstone should be present inside the gallbladder, but is not present inside the gallbladder. It is present somewhere in the intestine, right? So ectopic gallstone, features of intestinal obstruction, and pneumobilia, air inside the gallbladder. These are the things which you basically have in the Rigler's triad. Very, very important. Okay, now understood. Very, very small topic, but a very important topic. They keep on asking you again and again. Rigler's triad, these are the 3 components. That's fine, and they'll give you a clinical scenario around this. Okay, and you'll have to kind of diagnose it. Now let's come to the management. So how do you manage these particular patients if at all there is a gallstone ileus? So there is an intestinal obstruction. Obviously, you'll have to perform a laparotomy or something. Once you perform a laparotomy, you will remove the gallstone, right? Now, what are you going to do to this fistulous communication? Okay, so there is a fistulous communication between the gallbladder and intestine. Are you going to kind of remove this particular gallbladder, or you're going to kind of leave it there itself? Okay, what are you going to do? Okay, so what you're going to do is, ultimately you have to remove this particular gallbladder. Otherwise, the recurrent kind of gallstone ileus will keep on happening, right? But will you remove this particular gallbladder in the same setting, or you will remove it in the separate setting? So what you need to understand is that, again, we are not dealing with a normal physiology person. Okay, so here there is a patient who has basically already suffered from the intestinal obstruction. There's a lot of vomiting which would have happened. The patient might be dehydrated and all those particular stuff. And because of all these particular things, what you need to understand is uh, we usually perform the cholecystectomy a couple of months later, 1 or 2 months later. Okay, but if at all the question is basically talking in terms of, what, the patient is very physiologically kind of stable, the surgery lasted for only half an hour, blah blah blah, then you may say that, what, the gallbladder can be removed in the same setting. You understand my point? If at all the patient is stable, we can remove it. There's no contraindication to it. But why we don't remove? Because usually the patients are not stable. Because usually the patients are in the state of dehydration and everything. You understand my point? If at all nothing is mentioned, do not mark it as removing in the same setting. Mark it as removing in the second setting, 1 to 2 months later. Okay, so I hope you have understood this point. Very, very important. Okay, now then what we have, we talked about all these particular stuff. So frankly, what you need to understand in this particular flow chart, this Mirizi syndrome and the gallstone ileus should be over here, right? So they are the complications of the gallstone which is present in the gallbladder itself. Okay, so I hope you have understood this point. Now then we have a choledochal. Okay, so what is this particular choledochal? Choledochal means that the gallstone has basically gone inside the common bile duct, which is leading to an obstructive jaundice. Okay, now that's all fine. Now this choledochal can get converted into an ascending cholangitis. So why? Because what you need to understand is that there is a chance that there can be an infection, right? So there can be an infection in whatever the kind of a bile which is accumulated over there. Okay, so there can be an infection in whatever the bile has been accumulated over here, and then ultimately what is going to happen is that infection can ascend towards the liver, and this is what is called as an ascending cholangitis, right? Are you understand my point? So what do we have over here? We have a Charcot striate and we have a Raynaud's pentad. Okay, so the pain, fever, and the jaundice, Charcot striate. Along with that, if at all the patient is having neurological kind of symptoms and the hemodynamic instability, then that becomes a Raynaud's pentad. Okay, that's all fine. So if at all there is a patient with an what you call as in choledochal or let's say an ascending cholangitis, what is the management of these particular patients? How are you going to manage these particular patients? How are we going to manage the patients with a choledochal or an ascending cholangitis? I hope you are answering. You will manage it with ERCP, endoscopic retrograde cholangiopancreatography. Okay, so that is how you manage these particular patients preoperatively. But occasionally what happens, there can be an intraoperative detection. So you took the patients for performing a simple cholecystectomy, and during the surgery you found out that, what, this particular patient also has a like the stone inside the common bile duct. Okay, so intraoperatively you kind of find out this. Okay, so if at all you find that there is a what you call as a common bile duct stone intraoperatively, then what you're going to do? Okay, if at all you find this particular thing out, then what you're going to do is you're going to explore that particular common bile duct. Okay, what do you understand when explore? You're going to put an incision and you're going to remove that particular common bile duct stone, and after that what you're going to do is you're going to kind of close it over something. So what are you going to close it over? So what is this particular stuff? This is what is a T-tube. Okay, so you are going to close that particular common bile duct over a T-tube. Okay, so you're going to put a T-tube and you're going to close that particular common bile duct. Okay, now why do you want to put a T-tube? Because we all are humans, right? We all can screw up. So let's say if at all the surgeon screwed up and let's say there were 5 stones inside the common bile duct and the surgeon managed to remove only 4, 1 stone has been left behind. So in order to look for any residual stones, that is the reason why you kind of put this particular T-tube, and then what you do or what you perform through this particular T-tube is something which is called as a T-tube cholangiography. Okay, so what you do is you put in a dye through this particular T-tube and you kind of find this particular thing out. When do you kind of perform this? On post-op day 7. On post-op day 7, you perform this T-tube cholangiography. Now, inside, when you perform this particular T-tube cholangiography, if you are able to find the stone inside the common bile duct, residual stones are there, then what you do? You leave this particular T-tube there itself. Why? Because you want that particular tract to get matured. Okay, so you want that particular tract to get matured. So you leave this particular T-tube there itself for let's say around 3 to 4 weeks or something, and then what you do after that, you basically remove this particular T-tube and you go in with a choledocoscope and then you take that particular stone out. You understand my point? If at all there is a residual stone, you leave the T-tube there itself for let's say around 4 to 6 weeks. the tract gets matured, and then you basically go with whatever the choledochal scope and you remove that particular stone. But if at all this particular T-tube cholangiography shows that there is no residual stone, in that particular scenario, you can remove this particular T-tube on post-op day 9 to 10. Okay, I hope you're able to understand this point. Okay, now this is one of the simplest classifications, right? Bismuth-Strasberg classification. You all would have kind of read this. Okay, everybody remembers this by heart, right? Now, I find that many times the students kind of struggle a lot with this particular classification, but it's not really that difficult. Okay, so let me just walk you through it. It's very simple. Let's kind of learn it together. Okay, so what is this particular Bismuth-Strasberg classification? So first of all, what is this particular classification system for? So this is a classification system for the bile duct injury. Okay, so this basically is going to tell you about the common bile duct injury. So during the surgery, what you need to understand is that there is a chance that the common bile duct can get injured, right? So if at all that gets injured, what the classification system we have is Bismuth-Strasberg classification. Okay, now what is this particular type A? What is the Bismuth-Strasberg? Okay, first of all, let's try to understand what you basically do in the cholecystectomy. So you have a common, like the cystic duct is there, and then there's a gallbladder. So you apply the clips on the cystic duct. So clips you apply, rather 3 clips you apply, and then you basically cut the kind of cystic duct. 1 clip is towards the gallbladder, and the 2 clips are basically towards the common bile duct. You understand my point? And then you cut this particular cystic duct. This is how you basically perform the surgery. But let's assume that during the surgery, if at all, the clip which you had applied on the cystic duct has kind of fallen off. Okay, so it's kind of not there. So what is going to happen? The bile is going to get leaked from this particular cystic duct. So what is the type A? In the type A, what you are able to understand is that there is going to be the bile leak from the cystic duct. So what is the type A? There is a bile leak from the cystic duct. I'm not writing because I'm pretty sure that you have 100 notes in front of you where this particular classification system is written. I'm just trying to kind of help you understand this. Okay, so what is the type A? Type A is basically bile leak from the cystic duct. Okay, so I over exaggerated. Obviously, you might be having at least a couple of notes where this particular classification system is there. So just follow that, and I'll just try to spend time explaining it to you. Okay, right. Now, what about the type B? So if I ask you, tell me one bile duct injury, which type of the Bismuth-Strasberg classification there is no bile leak, or rather, if I ask you the question in this particular form that when you do an ERCP, the ERCP is kind of normal in this particular type of a bile duct injury. The answer is going to be B. Because here what you did, yes, you very well applied the clip on the cystic duct. Yes, that's great. But you also ligated and you applied the cyst, like the clip on the aberrant right hepatic duct. So because of this, what happened? The bile which was draining from this particular part of the liver, it's now getting hampered. I understand my point. So here you are basically ligating the aberrant right hepatic duct as well. So in the type B Bismuth-Strasberg classification, what you're basically doing, you have ligated the right aberrant hepatic duct as well. Okay, I hope you have understood this particular point. Very, very important. No bile leak, ERCP is going to be normal. What about the type C? In type C, what you have done is you have applied the clip on the cystic duct, that's fine. But in this right aberrant hepatic duct, in the proximal part, you did not apply the clip. So here what is happening? There's a bile leak which is happening from an aberrant right hepatic duct. Okay, so what was type A? Bile leak from the cystic duct. What was type B? You have ligated, cystic duct is ligated, that's great. But the aberrant right hepatic duct has also been ligated. What is type C? In the type C, the aberrant right hepatic duct proximal part has not been ligated, and there is a bile leak from the right aberrant hepatic duct. Okay, then what do we have? Type D. In the type D, what you have basically an injury in the common hepatic duct. Okay, and there is a partial injury to the common hepatic duct, and the bile is leaking from this particular common hepatic duct. Okay, I hope you have understood this particular point. A, B, C, D. I hope everybody have understood this particular point. Got it? Right. Now, what about the E? In the E, what we have is E1 to E5. Now, what is this E1 to E5? There is a complete rupture, or rather more than 50% of the circumference of this particular common bile duct has been kind of involved. So what is E1? E1, if at all, this is basically happening more than 2 centimeters from this particular confluence. Okay, so what is this? This is what is the confluence of the right and the left hepatic duct. So if at all there is a through and through injury which is more than 2 centimeters away from this particular confluence, that is what is the E1. E2 is basically less than 2 centimeters from the confluence. What is E3? Confluence is involved, but the continuity is maintained. Okay, conference is involved, but the continuity is maintained. Then what about the E4? Here the conference is involved and the continuity is not maintained. And type 5 is a bit weird one. So there's a stricture in the common hepatic duct with the ligation of the aberrant right hepatic duct. Okay, so I hope you have understood. So this is a very, very good image which I have found out, which I have been using for like last 2, 3, 4 years. But this is going to help you in remembering this Bismuth-Strasberg classification in a very, very well manner. I hope everybody have understood this particular point. If you want to revise it, please replay it. That will help you out. I'll just move on because already we are a bit kind of lacking behind. Okay, understood? So this is what is the classification system, Bismuth-Strasberg classification for your common bile duct injuries. Okay, now let's talk about a couple of more conditions over here. Choledochal cyst. What is this particular choledochal cyst? So this is basically a congenital swelling of your common bile duct. Okay, what do you understand by the congenital? So it is actually not congenital. The congenital anomaly is ABPJ. What is this ABPJ? Abnormal biliopancreatic junction. Okay, what is ABPJ? Abnormal biliopancreatic junction. So because of this, what is going to happen? The pancreatic juice is basically going to, like the pancreatic enzymes are basically going to go into the bile duct. They're going to kind of cause an damage to the wall of the particular bile duct, and because of this, the bile duct is basically going to end up dilating up. Okay, you understand my point? So this is what is the pathogenesis of the choledochal cyst. Now, obviously, in the children, they are going to present with the jaundice and everything. In the adults, they present with the pain and the mass and everything. That's all fine. Yes, you're right. So what we have is a Todani-Allenzo's classification. So what is this Todani-Allenzo's classification? So type 1 is fusiform dilatation. Type 2 is the diverticular dilatation. What do you understand by this fusiform and the diverticular? Fusiform basically means that it is a uniform dilatation. Okay, what is this? This basically means that it is a what you call as a uniform dilatation. What is a diverticulum? Diverticulum is basically non-uniform dilatation. So one part of the like wall of that particular lumen is basically dilating. Okay, so we have a fusiform, that is a uniform dilatation. Diverticulum means non-uniform dilatation. Then we have a type 3, which is choledococele. So what is this choledococele? So where this particular bile duct is entering into the intestine at this particular site, if at all there is a dilatation, this is what is referred to as your choledococele. Okay, so what is a choledococele? That there is a dilatation of this, like the point where this particular bile duct is entering into the intestine. Then type 4, A and B. A is basically intra plus the extrahepatic dilatation. B is just the extrahepatic, and the type 5 is basically what you call as a Caroli's disease. Okay, now in the yes, absolutely right. What you basically see this is what is a central dot sign. So I hope you're able to appreciate this. This is basically what you basically get on the contrast and on CT scan. So here you have a central dot, which is basically formed by this particular system, like a hepatic artery. I understand my point. So the branches of those and everything. So they are basically going to appear white, and there's going to be the cyst surrounding it. So this is what is referred to as a central dot sign, which you basically get on the contrast and CT scan in the Caroli's disease. Now, complications and all, it's fine. Okay, so complication is, one of the major complications is the malignancy. So it can lead to gallbladder malignancy, or it can also lead to the common bile duct malignancy. Okay, so cholangiocarcinoma, then like the gallbladder cancers, everything can develop from here. Okay, now what about the management? So if at all there is a dilatation, you cut it and you basically anastomose it with the intestine. So hepatic or jejunostomy and excision of the cyst, that's there. But if they specifically ask about the type 3 choledococele, it is going to be the ERCP with the sphincterotomy. So because what is the type 3 choledococele? This is a dilatation where the bile duct is entering into the intestine. So that terminal portion is basically getting dilated. So here you have to perform a sphincteroplasty. Okay, so ERCP with the sphincteroplasty. In the Caroli's disease, you cannot just remove the entire liver because the entire liver is having the cyst. So here you have to perform a liver transplantation. Okay, I hope you have understood this particular point, guys. Okay, now again, I'm just sharing a couple of informations for those who wish to kind of join. This is basically the QR code to my whatever the Instagram thing. This is what is basically your YouTube channel. If you are liking this particular content, you can consider subscribing it. And this is basically the code for whatever. You can connect with me on the WhatsApp and whatever, like I will add you to a group or something, and if you have some doubts, you can just send me and I'll discuss it with you guys. Okay, now I'll just take a couple of questions, then we'll be starting with what you call as a pancreas. So with cyst unroofing 2 in type 3, yeah, so sphincteroplasty basically, see, so there's a terminal portion which is basically dilating. So when you basically do a sphincteroplasty, ultimately you're basically kind of cutting that particular cyst itself. Okay, so that's fine. Caroli's disease management is what you call as a liver transplantation. As I told you, right, entire liver is basically having the cyst. You cannot just throw that particular liver off, or rather you can throw that particular liver off, but the patient will not survive, so you will have to put a new liver inside. I understand my point. So liver transplantation, so management of the Caroli's disease is liver transplantation. Understood? Got it, guys. Now let's move on to the pancreas. Now, what you need to understand is that I talked to you about what you call as reducing the number of silly mistakes and reducing the knee-jerk response and everything, right? So let's assume that after solving 4-5 difficult questions, question comes in front of you in which they're basically showing you the double bubble appearance. Okay, on the X-ray double bubble appearance, I'm pretty sure everybody have seen that particular X-ray, right? Now, if at all they give you a clinical scenario, and if at all in the options they have both, like the annular pancreas and the duodenal atresia, what are you going to mark? Okay, so please try to understand in this particular scenario, always you have to look at the vomiting. So if at all in the question they have mentioned non-bilious vomiting, then you will have to mark it as an annular pancreas. But if at all in the question they have mentioned as a bilious vomiting, then you will have to mark it as a duodenal atresia. So please do remember this particular point. Child on let's say day 1, day 2 of the birth, the patient is basically coming to you with a vomiting. On the X-ray, there's a double bubble appearance. If at all it's a bilious vomiting, probability of a duodenal atresia. 80% of the duodenal atresia have a bilious, 20% have non-bilious. Annular pancreas, usually they have a non-bilious vomiting. So please do remember this question has been asked. If at all they give okay. Okay, I think I'm back. Yep, I hope I'm audible and visible to you. Okay, that's great. Okay, I hope I'm audible and visible to you now. Okay, great. So, yeah, again, some technical glitch. I'm really sorry for that. Okay. Now, what about the annulopancreas? How do you want to manage this particular stuff? So, it's a duodenostomy. Okay, duodenostomy. So, that's how you're going to manage this particular annulopancreas. That's all fine. Okay. Now, what about the acute pancreatitis? What do you understand by acute pancreatitis? In the acute pancreatitis, what is happening is there is a premature activation of the enzyme. So, that is what is basically happening in the acute pancreatitis. Now, I have asked students, what is the most common cause of an acute pancreatitis? And so many times I have got the answer as an alcohol. Okay, so please remember that's not the correct answer. Now, this is one of the simplest questions which can be asked to you. The most common cause is basically your gallstone, guys. Okay, gallstone. Most common cause is your gallstone. Okay, and yeah, that's what you need to understand over here. The most common cause is definitely your gallstone. Understood? Right. Now, what else can happen? So, alcohol can happen. Alcohol is kind of one of the things. What is the ERCP? So, the most common complication. Okay, so the most common complication of the ERCP is your pancreatitis. Around 5% of the ERCP cases will land up into pancreatitis. This has been asked to you very, very recently. Then trauma can be there, kind of hypercalcemia can be there, hypertriglyceridemia, and the drugs. Okay, so all these are things are there. That's fine, but very, very simple question. The most common cause of an acute pancreatitis is basically your gallstone. Okay, understood? Now here the characteristic history is going to be the epigastric pain, which is radiating to the back. Okay, now if at all you have a characteristic history of acute thoracic pain, different question I'm asking you, please put it in the comment box. Acute thoracic pain radiating to the interscapular region, then what are you going to think in terms of acute thoracic pain radiating to the interscapular region? Then probably you will think in the terms of dissecting aorta. Okay, so aortic dissection, we talked about that. So there the characteristic history is going to be acute thoracic pain radiating to the interscapular region. Acute pancreatitis is like acute whatever the epigastric pain radiating to the back. Okay, now once they had given you a question where they had not given even this knee chest position, they've given you like a patient who is basically lying down on the bed with the knee chest position. Okay, so I hope all of you understand what is the knee chest position. So patient was in that particular position, and they had said that the patient basically has the pain of that particular condition is basically reduced, okay, released in this particular position. So what is the diagnosis of the patient? So they wanted you to mark it as an acute pancreatitis. They had asked you this. Okay, so I hope you remember the patient with the acute pancreatitis, they feel better in the knee chest position. Very, very important. Okay, now the important thing in the patients with the acute pancreatitis is in a paralytic ileus. So what is this particular paralytic ileus, and why is this particular thing going to happen? So what you need to understand over here is that because of the local inflammation which is going to be there, the local bowel loops will lose their peristalsis, and because of this the patients will land up into paralytic ileus. And that is the reason why the patients with an acute pancreatitis, they come to you with the nausea, vomiting, abdominal pain, and dehydration and all this particular stuff, right? Okay, right. Now then you have a Cullen sign, Gray Turner sign, Fox sign. I'm pretty sure all of you know this. What is a Cullen sign? It is basically the periumbilical ecchymosis. Gray Turner sign is basically ecchymosis in the flanks. Fox sign is basically ecchymosis in the inguinal region. In the labs, Amylase and the lipase can be done. Lipase is the most specific one, that's fine. Now, what is the indication of performing a CT scan? What is an indication of performing a CT scan? Can you please help me with this? Yeah, why do you want to perform a CT scan? Right. So, recondite leaning forward is basically the knee chest position. Okay. So, knee chest, when the knees basically come to the chest, that is what is a knee chest position, right? Okay. So, why do you want to perform a CT scan in the patients with an acute pancreatitis? What information are you going to get on the CT scan? You have already diagnosed, right? So, what complication I'm talking about? What complications? If the symptoms get more severe, okay, that's fine. Okay, so the specific answer I'm basically looking for is to look for necrosis. Okay, necrosis. Okay, so understood, right? Now, because for the investigation of choice, the gold standard, whatever, is the lipase. Okay, so if the lipase is positive, yes, definitely the patient is basically having an acute, what you call as a pancreatitis. Okay, pseudocyst is a very late kind of feature, right? Pseudocyst basically doesn't occur within 4 weeks. Okay, I'm talking at the time of presentation. That's what I'm talking about. Okay, so if I want to perform a CT scan, when am I going to perform a CT scan? Let's assume that you are a doctor, and you are a doctor, I understand, but let's assume that you are the treating physician and the patient has basically come 72 hours. Okay, why after 72 hours, KK? Absolutely right. So my question was, when are you going to perform a CT scan? Are you going to perform a CT scan immediately or later? So what you need to understand, you have to perform it after 72 hours. Why after 72 hours? Because this is going to give time for the inflammation to go up and then subside down. So whatever the necrosis has to happen, it would have happened. So after 72 hours, you will be able to accurately diagnose how much of the what you call as a necrosis is there or something like that. Are you understand my point? So the CT scan is basically done after 72 hours. That is something which you need to understand over here. Okay, now what the on the X-ray, what you're going to find, you can find the colon cutoff sign or the sentinel loop sign. All those particular things are fine. Now this particular table is just trying to tell you that, you know what, there are so many other complications which can happen over here. It is not just whatever the local complications or something like that. There are also the systemic complications which can happen. So it is an ARDS in the lungs. What you basically get is an ARDS. Then you can just go through the list. I'll not kind of spend time over here, but all again, nothing to kind of memorize away. I'm just trying to tell you that it's a very systemic kind of a feature. That's fine. Now, one thing which they had asked you in the past is that the vascular complications, okay, so the splenic artery aneurysm or the splenic vein thrombosis, these are because of what? Which enzyme? Amylase, lipase, elastase, protease. What exactly? What enzyme? So it is an elastase, okay? So in the vessels, what we have is elastin, right? So the elastase enzyme is responsible for the vascular complications. Do not mark it as a protease, okay? So yeah, that's what you need to understand. So now you have kind of diagnosed the patient, okay? So the patient came, the patient had acute epigastric pain, which was radiating to the back and everything, and you did a lipase is positive. Done, right? So do you need any more information before you start the treatment for this particular patient? The answer has to be yes, right? Now we want to know what is the severity of this particular patient. Okay, so for the severity of this particular patient, what we have all these particular things: Ranson scoring system, modified Glasgow core, bicep scoring system, Apache 2, C-reactive protein, CT severity index. All these particular scoring systems are there because we want to look for the severity. How severe are the symptoms of this particular patient, right? Are you understanding? So based on this, you basically classify the patients into what you call as a acute, like the mild pancreatitis or the severe pancreatitis or something like that. Okay, now you have to kind of go through this. You have to remember the Ranson scoring system. You have to remember the bicep scoring system. Do remember this. Apache 2 also is kind of important. They had asked you once, which of the following is not a finding of the Apache scoring system? So I'll not spend a lot of time, but these are the physical examination findings. These are the lab findings. Now, if you just in your mind, if you just think about that, you know what, if at all I ask you that any particular patient you have to kind of examine and you have to kind of send some basic labs, these are the things which you will end up kind of doing, right? So obviously you're going to like check for the vitals, BP, temperature, heart rate, respiratory rate. You're going to see whether the patient is basically well oriented to the time, place, or person or not. So GCS, all these particular things you're going to kind of see. That's all fine. Along with this, what you're going to see is that yeah, so you're basically going to look for the basic blood work, right? So the creatinine, the WBC count, sodium, hematocrit, oxygen, pH, and the potassium. Okay, so please try to understand this point. All these particular things you are going to kind of see. Remember this, okay? So why this is important, guys? Because they had asked you a question on this. Once they had asked, which of the features is not a part of your Apache 2 scoring system, right? Now, Okay, and this is an Apache 2. It is not specific for the pancreas. It is basically the physiological scoring system. So just go through it and just remember it. Okay. Now this is basically a flow chart, which basically, again, I'll share this particular PPT with you. But what you need to understand, this particular flow chart is going to help you in understanding the entire acute pancreatitis in a very, very good manner. So when the patient comes to you, diagnose it with help of Amoebic, lipids, blah, 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 whatever. After that, that is not enough. You have to kind of assess the severity. So you look for the severity and everything. Then you basically divide the patients into the mild acute pancreatitis and the severe acute pancreatitis. Management is more or less similar. I'll just walk you through it. So again, in the severe acute pancreatitis, you just become a bit more serious about the patient. That's all about it. Okay. Now the fluid resuscitation, obviously, because the patient is vomiting because of the paralytic ileus and everything. Please pay attention over here. Many questions are asked from these particular small box and everything. Okay, so very important, the application of this. Okay, so first is fluid resuscitation. Why do you want to want a fluid resuscitation? Because there is a dehydration. Why? Because the patient was continuously vomiting and all those particular things. There is a third space loss and all those particular reasons, right? Then initially you keep the patient's NPO. You ask the patients, you know what, don't eat anything. Why you don't eat anything? So earlier thought process was that, you know what, we have to give the pancreas a bit of a rest. Okay, so because if at all we give the patient's food, what is going to happen? The pancreatic enzymes will again start to get activated, which will further exacerbate the acute pancreatitis. All those particular concepts have been thrown out of the window now. So what you need to understand, but you still keep the patient's NPO. Why do you keep the patient's NPO? Because the patient is not able to eat anything. Patient is vomiting out because of the paralytic ileus. Are you understanding my point? So the reason for keeping the patient's NPO is this. Okay, understood? Now, you put the patients in the nasogastric tube. Why do you put a nasogastric tube? For the ileus, as has been written over here. Now, this is something which you need to understand over here. Enteral feeding. Okay, so the enteral feeding when tolerated. So what is this particular when tolerated? When the patient's paralytic ileus basically resolves. So when the patient stops vomiting or the patient basically passes the stool and the flatus and everything, at that point of time you have to initiate the enteral feeding. Early enteral feeding initiation is the key. I hope you've understood this particular point. So this is, I'm just kind of emphasizing on this because this is going to re-emphasize that the concept that giving pancreatic rest is out of the window. That is not kind of followed in today's time. Okay. Now, what was the most common cause of an acute pancreatitis? Gallstone, right? So you have to perform ERCP. If at all there's some gallstone stuck, you have to kind of take it out. And then if at all the patients are not improving, then after 72 hours, you can perform a CT scan to look whether the necrosis, infected necrosis, everything is there or not. Now, if we talk about the severe acute pancreatitis, more or less the things are similar. It is just that you are basically a bit more serious about it. You shift the patient to ICU and everything. And the TPN if the enteral feeding is not tolerated. So because if at all there is a severe acute pancreatitis, there is a chance that the paralytic ileus will be prolonged. And in that particular scenario, you have to start the patients on the TPN. Then you perform a CT scan whether the pancreatic necrosis is present or not. If at all the pancreatic necrosis is present, then you basically see whether it is infected or not. But if at all it's an infected, then you have to perform a surgery, that is a pancreatic necrosectomy and all those particular stuff. Okay, so you can just go through it. What is this particular CT scan? So there's a patient who basically had an acute pancreatitis, let's say 5 weeks back, and now the patient is basically coming to you with an abdominal pain. You performed a CT scan and this is what you found. So what is the diagnosis? The diagnosis is pseudocyst. What are you basically seeing over here? This is not the stomach. This is not the distended stomach. What is this? This is basically your pseudocyst of pancreas. Okay, so what is this? This is what is a pseudocyst of the pancreas. Okay, now, so what about the pseudocyst? Only a couple of things which you should remember. There are too many things to remember, but just remember a couple of things. Okay, so I hope you've understood why it is called as a pseudocyst, because it is not having any true epithelial lining. What is it formed of? It is basically formed of granulation tissue. Okay, it is basically formed of a granulation tissue. It is not having any what you call as a true epithelial lining. Okay, so that is what you need to understand. What is the management of the patients with the pseudocyst? It is conservative. Okay, it is conservative management. Okay, so how do you manage these particular patients? It is conservative management. But if at all the size of the cyst is, let's say, more than 6 centimeters, or if at all it has been more than 6 weeks from the diagnosis or something like that, in that particular scenario, or the patients are symptomatic, very important. Okay, so your love and Billy kind of emphasizes a lot on the symptomatic, and you have also been tested on it. So if at all the patient is symptomatic, it doesn't matter what the size is, it doesn't matter how much the duration is, you have to go ahead with an excision. Like you have to kind of go ahead with a management. So you have to kind of go ahead with the cystobiliary drainage or the cystojejunal drainage or something like that. I understand my point. Very important to I'm re-emphasizing on this. if at all they have given you symptomatic. What do you understand by symptomatic? Bleeding has happened, or let's say there's a severe pain, or the patients are basically having what you call as early satiety, and all any particular kind of a symptom is there. In that particular scenario, the size of the cyst and the duration of the cyst doesn't matter. Okay, right? I hope you have understood this particular point. Very, very important. Okay, now I'll not be able to cover these particular things. Okay, so what I'll do is I'll just quickly go on to the urology now. Okay, so we have talked about the acute pancreatitis in detail and everything. Let's kind of move to what you call as a urology. Okay, now in the urology, what you need to understand, the first thing is about the stone. I'm not covering about the pathogenesis of the stone and the different types of the stone and everything. I'm pretty sure that you guys would have known that. Now, if I ask you about the investigations of the stone, I'll try to kind of build this a couple of concepts with you guys. So what is an investigation of choice for any particular like a renal stone? What is the investigation of choice? Please remember, it is a non-contrast CT scan. What is the investigation of choice? It is a non-contrast CT scan. That is what is an investigation of choice. Okay, please remember this particular point. Okay, it is not an X-ray, it is a non-contrast CT scan. Okay, then on the urine examination, what are you going to get? Okay, so you basically get something which is called as a crystals. Okay, so what you basically get, something which is called as a crystal. So what kind of crystals do you get? So please remember this. Dumbbell shaped crystals are basically seen in calcium oxalate monohydrate. Okay, dumbbell shaped crystals, calcium oxalate monohydrate. Then what we have, bipyramidal or the tetrahedral crystals. Okay, bipyramidal or the tetrahedral crystals. These are the ones which are seen in what you call as a calcium oxalate dihydrate. Then rosette and everything is fine. You can just forget about this. This also you can forget. Just remember this. Cuff and lid crystals are basically seen in your Staghorn calculus. So do not forget these particular stuff. Dumbbell shaped crystals, calcium oxalate monohydrate, envelope shape or the tetrahedral crystals, calcium oxalate dihydrate, cuff and lid crystals are seen in Staghorn calculus. And do not forget the cystine crystals. Okay, so hexagonal crystals are basically seen in cystine. Okay, I'm pretty sure that you would have seen the microscopic images of that as well. If you have not, please do have a look about this. The cystine is asked quite a lot of times. Okay, struvite is the same. Okay, struvite is the Staghorn calculus. Cuff and lid crystals is the struvite. Okay, so I hope you have understood this point. Okay, right? Okay, now what about the X-ray? 90% of the stones are opaque. Okay, what about the gallstones? How many percent of the gallstones are opaque? 10%. Okay, this is directly given on your Love and Billy. It's written in the footnote of one of the images. So 10% of the gallstones are radiopaque. 90% of the kidney stones are basically radiopaque. Okay, now let's not kind of cover this IVP and everything. That's all okay. Okay, but the investigation of choice I told you about is a non-contrast CT scan. Okay, now whenever you have a patient with a, let's say, a stone, a kidney stone or the ureteric stone or something like that, what is going to be the management? So you can go ahead with the conservative management. Okay, right. Right. Okay. So what you need to understand over here, conservative management. Conservative management is used when the size of the stone is less than 5 millimeters. Please remember this point. Okay. What is this particular conservative management? You ask the patients to kind of drink a lot of water, 3.5 to 4 liters of the water. You give the patients alpha blockers. Why? Because you want to kind of relax the lower end of the ureters and everything. So you give the patients tamsulosin, that is an alpha blocker. You give the patients a lot of fluids. Sometimes you can give steroids as well, but there's not very much indication of that. But yeah, you can give the steroids, and then this is basically called as a flushing out therapy. But this has to be done only if at all the size of the stone is less than 5 millimeters. Okay, then the other options are ESWL, PCNL, URS. We'll talk about that. Okay, so first is ESWL. What is this particular ESWL? You bombard the stone with the extracorporeal shock wave. So with the help of the shock waves, you bombard this particular stone. So what happens is the stones basically are broken down into the small pieces. Okay, so the stones are broken down to the small pieces, and these particular small pieces can basically come through the ureter. Okay, now the complication of this is the pain. Obviously the pain can happen, okay, because these particular smaller pieces are coming through the ureter, so the pain can happen. Then hematuria. So obviously because of so much of bombardment of the kidney, the microvasculature of the kidney, they can get ruptured, and because of that hematuria can be happening. Okay, that's fine. Now this is again important, infection and the sepsis. So what you need to understand is that inside the stone there is a bacteria which is basically lying dormant. Now what you have done is you have basically gone and you have bombarded that particular stone. So what has happened? The stone has kind of broken down and the bacteria basically are awake now. And now you also have whatever the lot of bleeding which is happening. So the bacteria can easily enter through the blood into the blood, and it can lead to the full-blown sepsis. So this is very important. Okay, so the most common complication of this particular ESWL, the pain and the hematuria, but yes, the infection can also occur. Then what is the strain stress? Strain stress is basically that when the lower end of the ureter, what happens is that the lead fragment, okay, so let's assume that there is a big stone. If I kind of throw it on the ground, all the pieces will not be of the same size, right? Some stones will be broken down into the smaller pieces, some will be of the larger pieces, something like that. So in the similar manner, if at all you have some lead fragment, that particular lead fragment can get obstructed at the uretrovesical junction, and then all the other stones can line up behind it. Okay, so this is what is referred to as your stream straws. Okay, then we have a cardiac arrhythmia. So cardiac arrhythmias, all these particular things can happen. That's all fine. So what is an indication of, okay, so what is a contraindication? Very, very important. So two, what you call as a absolute contraindications of performing this particular ESWL. Very, very important. Pregnancy and the bleeding disorder. I told you, right? The bleeding is one of the complications of this. So if at all there is a patient with is having what you call as a bleeding disorder, or the patient is pregnant, ESWL is absolutely contraindicated. Okay, so what is an indication? What is the size of the stone cutoff where you basically perform this particular ESWL? It is less than 2 centimeters. Okay, so it is less than 2 centimeters. Okay, it is less than 2 centimeters. Okay, I hope you have understood this particular point. Less than 2 centimeters. Okay, right. Now there are the other relative contraindications as well. Hard stones. Which is the hard stone? So we have calcium oxalate monohydrate, that's one of the hard stones. Cystine stones are the hard stones. Okay, so these are the things. Okay, obese patients, forget about it. Let's not go into the everything. A couple of takeaways from the CSWL which you cannot forget is that what it is, you understood it now. What are the most common complications? Pain and the hematuria. What is the absolute contraindications? Pregnancy and the bleeding disorder. And what is the preferred size of the stone? Less than 2 centimeters. We'll cover it up. Okay, then we have a PCNL. Now how do you perform it? Forget about it for a moment. So what you basically do in the PCNL is, you go through the skin, you go through the muscles and the kidney and everything, you reach into the pelvic LSS system, and then you kind of look at the stone, you break that particular stone into smaller pieces, and you bring those particular pieces out. So this is what is referred to as your PCNL, percutaneous nephrolithotomy. Okay, understood? Right. So what are the complications of this? So hematuria. Okay, obviously you're going through this, whatever, the skin and the muscles and the renal parenchyma and everything. So bleeding is invariable. Okay, so bleeding is definitely going to happen in these particular patients. Very, very important. Okay, then the indications are whatever the contraindications of the ESWL were there, they will be the indications of this. The stone size of more than 2 centimeters, hard stone, obese patients, all those particular things are fine, but mainly the stone size of more than 2 centimeters, you basically have this whatever the PCNL. Okay, then what are the contraindications? Exactly that of the ESWL. Bleeding disorder. As I told you that if you are going through the kidney, obviously some amount of bleeding is going to happen. Bleeding disorder is absolutely contraindication. Pregnancy. Pregnancy is also contraindication because you want to use a lot of what you call the fluoroscopy. Okay, obviously because you want to kind of manipulate your instruments and everything. So obviously fluoroscopy is the integral part. Without fluoroscopy, you cannot perform the PCNL, and that is why it is contraindication. Okay, I hope you have understood this point. Okay, right. Now that's all fine. And again, like the position as well, because in the PCNL, what you have to do is you cannot operate on this, like you can operate in the supine as well. Nowadays, you do a supine PCNL, but traditionally the PCNL is basically performed in the prone position. So obviously you cannot keep the pregnant females prone, right? I hope you have understood this point. Okay. Obese patients, PCNL, RIRS. Okay, so what you need to understand is, right. So the content, it's not like so white and black. I understand where you're coming from, but you cannot have this particular white and black. Okay. So for the obese patients, as I just told you, so what is the problem with the obese patients? Okay. So just think for a minute, why you cannot perform a PCNL in an obese patient? So you can very well perform that. The problem basically becomes when you basically keep the patients prone. So first of all, so you intubate the patients, and after the patients have been put under anesthesia, then intraoperatively have to make the patients from the supine to the prone position. So you understand my point? So that is one of the difficulty. Second is that if at all the patient is very, very obese, the respiration of the patients during the surgery will get hampered. So this is the main problem with the obese patients. Okay, so that's why I told you that we have come up with something which is called as an supine PCNL. So nowadays there is the newer method which is basically called as a supine PCNL. In the supine position only you can kind of perform in PCNL. And we have also come with something which is called as the ECRIRS. So it basically means that we can perform an RIRS and the PCNL at the same kind of, because the patient is supine, so you can also perform an RIRS, you can also perform a PCNL. So with the help of both, you are able to kind of manage that. Okay, so I think that you would have read something somewhere, or somebody would have talked about this or something, but it's absolutely bizarre. Nobody will ask you that in the obese patient, which is kind of what you should do, PCNL or RIRS. It's an absolutely bizarre question to be asked. First of all, how much obese, like what is the BMI and all those particular stuff. So let's not go there. I hope you have understood, right? So it's not that white and black and something like that. Understood? Got it. Right. Right. So now let's talk about, okay, obviously this is not a digestion, this is basically a dormia basket. Okay. So then what we have is a URS. So that is ureterorhinoscopy. Okay. So ureterorhinoscopy. Okay. So here what you basically do is you go in through like there is a kind of a semi-rigid ureteroscope. You basically go through the urethra, you go through the ureter, and then inside the ureter you have a stone. You basically break that particular stuff and you kind of bring it out. In order to bring that particular thing out, what you have something which is called as a dormia basket. Okay, so dormia basket. So what is this? This is what is a dormia basket. You basically send it in a closed kind of a position. You pass that particular stone, you open that particular dormia basket, and then you pull it out. What you basically do is you take that particular stone out. Okay, so that is what is a dormia basket. Now the indications of this is the pregnancy. Okay, so in the pregnancy, even in the bleeding disorder, if the patient is having a bleeding disorder, you can do that. Okay, so if at all, let's say there is a patient with a bleeding disorder, you can perform this. Okay, so in the pregnancy also you can perform this. Okay, the complications is the ureteric injury. Okay, so chances of the ureteric injury are slightly higher in this particular stuff. Okay, I hope you have understood this point. Now this is again a table which you should remember. Based on this, a lot of MCQs will get solved, but obviously this is not what we basically do in the real life. Like in the real life, we basically have a bit more modification of this, but for you, if you remember this particular table, that's going to be good enough. I'll just walk you through this table. Just give me a minute. Okay, so this basically summarizes the management of the renal stone. So what you need to understand is the stone can be either in the kidney or in the ureter. Now in the kidney, the stone can be either more than 2 centimeters or less than 2 centimeters. So if at all you have a renal stone which is more than 2 centimeters, the management of that is PCNL. Okay, it's a PCNL. But if at all there is a stone in the kidney which is less than 2 centimeters, or there is a stone in the ureter, like which is present in the upper ureter or the middle ureter, and the size of the stone is less than 1 centimeter. In that particular scenario, what you can perform is ESWL. Okay, so what you can perform is an ESWL. Are you understand my point? Ureteric stone in the upper and the middle ureter less than 1 centimeters, ESWL can be performed. Why not in the lower ureter? Because in the lower ureter you have a it's bounded by the bony pelvis, right? So it is bounded by the bony pelvis. So even if you kind of put the kind of whatever the shock waves or something like that, they will not be able to kind of go through. Okay, because it is bounded by the bony pelvis. Are you understand my point? Then finally, if at all the stone is in the lower ureter, or if at all the size of the stone is more than 1 centimeters in the ureter, then you have to perform this URS, like endoscopic removal. Okay, so ureterorhinoscopy karke you'll have to kind of take it out. And in the ureterorhinoscopy, so I told about this, right? URS. So this is similar like the RIRS. Okay, so what is this RIRS? RIRS, the full form is retrograde intrarenal stone surgery. So with the help of this particular scope, if at all you're able to go to the kidney, for that you will need a flexible scope. And in the ureter, you can go with the semi-rigid scope only. You understand my point? So this is what is called the ureterorhinoscopy. Ureterorhinoscopy. With the scope, you are going into the ureter and the kidney. So URS, ureterorhinoscopy, RIRS, retrograde intrarenal stone surgery. Okay. So I hope you have understood this particular point, guys. Okay. Right? Understood. Got it? Right. Now, let's talk about the emphysematous pyelonephritis. So what was the most common organism which was responsible for the emphysematous cholecystitis? Most common organism which was responsible for the emphysematous cholecystitis. What was the answer? It was Clostridium, right? So what is the most common organism which is responsible for the emphysematous pyelonephritis? For the emphysematous pyelonephritis, what is the most common organism which is responsible? Can you please help me with this? The answer to this particular question is E. coli. Please do not mark it as a Clostridium, guys. Okay. So over here, the most common organism which is kind of is there is an E. coli. Please remember this, guys. Okay. So here, what they're going to give you, they're going to give you the history with the clinical scenario that there's a patient with an uncontrolled diabetes, and they are going to have pneumaturia. Okay, so all these particular things are going to be there, right? Fever and frequency of the urination, all the features of the urinary tract infection is going to be there, but there's going to be the pneumaturia. It means that air in the urine. Okay, air in the urine is pneumaturia. So most common organism is E. coli, and there's going to be the pneumaturia, right? So that's all fine. So investigation of choice is a CT scan, because on the CT scan, if you have the air focus inside the kidney, that is what is an emphysematous pyelonephritis. What about the treatment? The treatment is percutaneous drainage with the nephrectomy. Okay, so you have to kind of do a percutaneous drainage of that particular stuff. So that is what you need to understand. Percutaneous drainage with the nephrectomy, that is what is the treatment. And overall, emphysematous pyelonephritis has a poor prognosis. Okay, it has a very, very poor prognosis. The mortality is very high. More than 50% is the mortality for the emphysematous pyelonephritis. Okay, I hope you have understood this particular point. Now, in the okay, so a couple of things which you absolutely need to remember in the emphysematous pyelonephritis is Most common organism E. coli, and then the pneumaturia, that is air inside that particular whatever this air coming through the urine. The CT classification is called as a Wong and Wong classification. So you would have read about that particular in radiology. Once they had asked you this, please remember Wong classification is basically there for the emphysematous pyelonephritis. This has a very poor prognosis, 50% mortality is there. Okay, now genitourinary tuberculosis, what you need to understand is that it is never a primary tuberculosis. It is always a secondary tuberculosis. It means that somewhere inside the body there has to be some kind of active focus, and then the bacteria would have traveled through the blood into the genitourinary system. Now in the genitourinary system there are so many things. So what is the most common organ which is involved in the genitourinary system? It is predominantly kidney. Okay, because obviously the most of the blood is basically going to the kidney itself, right? So the kidney is going to be affected. So rest of the organs are like the ureter and the bladder and everything is going to be affected by the descent of that particular organism from the kidney into the ureter and to the bladder and everything, right? Now the characteristic thing which you are basically going to get in the genitourinary tuberculosis is called as a sterile pyuria. Okay, so what is this particular sterile pyuria? It basically means that when you do a routine microscopy of that particular kind of urine sample, you're going to get a lot of WBCs. Okay, so WBCs are elevated. Okay, but when you culture that particular urine, you are not getting any particular organism, because usually whenever the WBCs are elevated, you think that there is some kind of bacteria which is present, and then you culture it, so you get a growth, E. coli, whatever, protease or whatever. Okay, you get that particular stuff, right? But in this, the like organism is not going to grow in the normal agar, and that is what you need to understand. That is why what you basically get is a sterile pyuria. Okay, now in the urinary bladder, I'll not be able to cover everything. In the ureter, what we say, okay, so in the kidney, what happens, there is a formation of a granulation, then the cortical abscess forms, and that particular cortical abscess ruptures, and all those particular things happen. Then in the ureter, very important, please remember, in the ureter there is a formation of a strictures. Okay, in the strictures, in the bladder, what happens is that there is something which is called as a thimble bladder. What do you understand by the thimble? This thumb is basically thimble. So very small capacity bladder, 20-30 ml kind of capacity of the bladder. That is what is referred to as a thimble bladder. That is what you basically get in the urinary bladder, thimble bladder. And then you get a Golf hole ureteric orifice. Okay, Golf hole ureteric orifice. Okay, for the diagnosis, what you basically have to do, 3 consecutive urine samples. Early morning samples have to be given with the thought process that overnight the tuberculous bacilli would have got excreted into the urine and everything. So the diagnosis is basically, the 3 consecutive urine samples have to be given or something like that. And yes, the putty kidney, cement kidney, do Google the X-ray of that. Okay, so this has been asked very recently in the AIMS exam. Also, it has been asked. I don't have it at this point of time, but I hope you have understood. Putty kidney or the cement kidney, this is what is an autonephrectomy, which basically happens in the last stage of the genitourinary tuberculosis. Important. Okay, so don't kind of confuse it with a Staghorn calculus. So just look at both these particular images side by side. Staghorn calculus is different, putty kidney, cement kidney is basically a bit different. Okay, how to differentiate thimble bladder from the bladder stone. So it's absolutely kind of different, right? Thimble bladder is basically small capacity bladder. There's no calcification inside that. In the bladder stone, I do have an X-ray, I'll show it to you. So in the bladder stone, you have a kind of radio opaque shadow inside that particular urinary bladder. Okay, so thimble bladder basically means that the capacity of the bladder is very less. You cannot distinguish on the image because they are like absolutely different kind of pathologies. Okay, I hope you have understood. Okay, recorded. I hope you have understood this point. Okay, now what is this? This is what is an polycystic kidney disease. Now the polycystic kidney disease can be autosomal dominant polycystic kidney disease, or it can be what you call as a autosomal recessive polycystic kidney disease. Okay, so ADPKD and ARPKD, those particular things can be there. ADPKD are of 2 types, ADPKD1 and 2. What is the chromosome number for the ADPKD1? It is 16. What is the chromosome number for ADPKD2? It is 4. Okay, 4. So 16 and 4. Okay, so please remember it's multiple of 4 only. Okay, so that is what you need to understand. Right, now in the autosomal recessive polycystic kidney disease, what you need to understand, the manifestations of that is going to happen in the intrauterine life. So what is going to happen? The fetal urine is going to be very less. Because of this, the patients are going to have oligohydramnios. Because of this, the lungs are not going to develop, and because of this, all those Potter faces and the Potter sequence are going to happen. And that is why the autosomal recessive polycystic kidney disease, the patients are not able to survive. They will not be able to survive. That's what you need to understand, right? In the autosomal dominant polycystic kidney disease, why will they not be able to survive? Because the lungs are not getting matured because of the oligohydramnios, the Potter sequence. I'm pretty sure you would have read about this in OBGY as well. Okay, now coming to the autosomal dominant polycystic kidney disease. The autosomal dominant polycystic kidney disease, again, this is going to be there since birth, but the manifestations are going to start in the adulthood at around 30-35 years or something like that. Now they are obsessed over asking you the extrarenal manifestations of the autosomal dominant polycystic kidney disease. So what are the extrarenal manifestations? First is the cyst. Most common extrarenal manifestation is the cyst. What is the most common organ which is affected? Liver. Okay, it can happen in the other organs as well, like the spleen and the lungs and all those particular stuff. But the most common extrarenal organ where the cyst develops is the liver. Second thing is inside the brain, what do you get? You get a berry aneurysm. Okay, berry aneurysm. Inside the heart, what are you going to get? You're going to get what you call as a mitral valve prolapse. Okay, mitral valve prolapse. Inside the colon, what are you going to get? Colonic diverticulum. So the way to kind of remember it, that everywhere the things are becoming very, very loose and they're becoming floppy. Are you understand my point? So there is going to be the cyst in the liver. Inside the brain, again, the vessels is becoming floppy. So there is a berry aneurysm. Inside the heart, the valves are becoming floppy. So there is a mitral valve prolapse. Inside the colon, what is happening? There is a colonic diverticulum. Understood? Now, the presentation of the patients with the autosomal dominant polycystic kidney disease is going to be the hypertension. They're going to present with the hypertension and the chronic renal failure and all those particular stuff. Okay, now pain can be there. Okay, pain can be there, but occasionally what happens? The bleeding happens in these particular cysts. As you can see over here, there is a hemorrhage which has happened in this particular cyst. So, if at all they say that there is a patient who is diagnosed case of an autosomal dominant polycystic kidney disease and there is an acute onset severe pain, it basically tells you that there might be a bleeding inside that particular cyst. So that is what you need to understand over here. Okay. Now the problem with these particular patients is that there is what you call as a renal failure, and that is why the management of these particular patients is a kidney transplantation. Okay. So what is the management? It is a kidney transplantation. Okay. Right. So the cysts will be seen everywhere, guys. Okay. So the cysts will be seen in predominantly they are going to be seen in the liver. The second, they can be seen in the spleen, the pancreas. They can be seen in the lungs as well. Okay, it's not like that it will not be seen, but they're very, very rare. But the most common extrarenal manifestation is basically the liver. Okay, but if at all they give you, where will you not see the like the cyst in the autosomal dominant polycystic kidney disease? Kidney, liver, spleen, lungs. Then you can mark it as a lung. So it is very, very rare. Okay, that's what you need to understand. So I hope you have understood. Usually they ask you what is the most common site of the cysts and the extrarenal site of the cysts and the autosomal dominant polycystic kidneys. That is what is going to be the liver. Understood, Satyaja? I hope you have understood, right? Okay. Right, so that is all about the autosomal dominant, and yeah, as I told you that the patients are going to land up into chronic renal failure, and ultimately the preferred treatment is going to be your kidney transplantation. Now, what is this? Important X-ray. So, can you please tell me the diagnosis of this particular patient? So, the diagnosis of this particular patient is horseshoe kidney. I hope you are able to appreciate. Okay, first of all, what is this particular investigation? This is an IVP, intravenous pyelography. So, the dye was injected and the dye has been excreted by the kidney and everything. So, what are you able to appreciate? That this is the outline of the kidney which you are having. Okay, so this is the outline of the kidney, and what is this? This is basically horseshoe kidney. Okay, what is this? Horseshoe kidney, right? Okay, right. Now, okay, so this is a congenital thing. Now, what is the problem with the horseshoe kidney? The problem, okay, first of all, the kidneys, are they formed inside the abdomen or they are formed in the pelvis? So the kidneys are basically formed inside the pelvis. Now, what happens is that in the horseshoe kidney, what happens that the lower pole of these particular kidneys, they basically fuse with each other. So lower pole basically fuses with each other. So what happens is that the kidneys, okay, normally embryologically what happens, the kidneys, they start their development inside the pelvis and then they gradually ascend into the abdomen. Okay, then they ascend into the abdomen. Now in the horseshoe kidney, what has happened? The lower pole of the kidney have kind of fused with each other. So what is going to happen? The ascent of the kidney is going to be stopped by something. So it is going to be stopped by what? It is going to be stopped by the inferior mesenteric artery. Okay, it is going to be stopped by the inferior mesenteric artery. That is what you need to understand over here. Right, so that's all fine. So usually the patients are asymptomatic, they don't even know that, and they basically go for a routine ultrasound or something, and then they found that, oh, I have a horseshoe kidney. Okay, so probably 1 in 250 people basically have it. Okay, so probably, you know, obviously the population which is watching at this point is very, very low, but yeah, I hope you got the understanding, right? In the general population, there are so many people who are moving around with the horseshoe kidney. Understood, right? Okay, that's fine. Now, important thing is they ask you the isthmus. Isthmus lies at which level? So what you need to understand is that the inferior mesenteric artery originates at L1 level. So the estimates is basically going to lie at the L2, L3 level. So please try to understand this. It is below that. So it is going to be lying at the L2, L3 level. Okay, so that is what you need to understand over here. Now, the most common manifestation is basically asymptomatic. They're usually going to be asymptomatic. That's all fine. The patients may present with the what you call as a UTI and all those particular stuff. So yeah, they may present with all this particular stuff, but most commonly they are asymptomatic. In the IVP, all of you know that the shake hand appearance and the flower vase bend of the ureter and everything, those are the things which you're going to find on the IVP. Now the risk, okay, forget about all these things. There's an increased risk of Wilms tumor. Okay, so the risk of the renal cell cancer in the horseshoe kidney is same as that of the general population, but the risk of the Wilms tumor is more in the horseshoe kidney. But if I ask you that what is the most common kidney tumor which is going to happen in the patient with the horseshoe kidney, the answer is going to be the renal cell cancer. I hope you're able to understand, right? Overall, the incidence of the renal cell cancer is definitely more, but as compared to the general population, when you compare them head to head, the risk of the Wilms tumor is more in the horseshoe kidney as compared to that of the general population. Not a very, very important point. It was just written on the slide. That's why I'm kind of covering it over here. I hope you have understood this particular point. Okay. Now, many students have a myth that, you know what, you can never cut this particular estimates. You can very well cut the estimates, not a very, very big deal, but you will not just cut the estimates just for the sake of it. Are you understand my point? So the management is not cutting off the estimate, that's fine. But let's say if at all due to some or the other reason, if you have to cut the estimates, let's say if at all there is some renal tumor or something like that, then you can very well cut the estimates. Obviously, it's a bit difficult surgery, but you can very well do that. Okay, so I hope you have understood this point. Okay, now what is this? This is what is the duplication of the ureter, and this is very, very important. Okay, so here the very, very important thing which you need to understand is something which is called as a Wiegert-Mayer law. What is this particular Wiegert-Mayer law? So Wiegert-Mayer law basically says that if it, okay, first of all, what is the duplication of the kidney? Duplication of the ureter. So duplication of the ureter basically means that there is one kidney and the one kidney is usually drained by one ureter. But if at all the single kidney is basically drained by the two ureters, this is what is referred to as your duplication of the ureter. Okay, I hope you have understood. Now, what does this particular Wiegert-Mayer law say? Wiegert-Mayer law says basically that if at all there is a ureter which is draining the upper pole of the kidney. Okay, so as you can see over here, this is a ureter which is draining the upper pole of the kidney. So what is going to happen? This particular ureter is going to open distally and medially. Okay, so it is going to occur. This is going to open distally and it is going to open medially. And this particular thing is always going to be stenotic or obstructive. Okay, so I'll repeat. The ureter which is draining the upper pole of the kidney is going to open distally and medially, and this is the one which is going to be the stenotic or obstructive. Okay, now the ureter which is basically draining the lower pole of the kidney, that is the one which is going to open proximally and laterally, and that is the one which is going to be refluxing in nature. Okay, so that is the one which is going to be refluxing in nature. I hope you have understood this particular point, guys. Okay, so very, very important. This is what is referred to as a Wiegert-Mayer law. Okay, now the another important thing. Okay, so we'll come back to this particular image. Okay, so a very, very important thing is the most common. Okay, so if I ask you what is the presentation, if at all there is a female which is going to have this particular duplication of the ureter, what is going to be the presentation in that particular female? So please try to understand the presentation in that particular female is going to be that there is a dribbling of the urine. Okay, so there's going to be the dribbling of the urine, continuous dribbling of the urine. Along with that, the patient is also going to give you the history that, you know what, the patient is able to pass the normal urine as well. Are you understand my point? So the characteristic history will be the continuous dribbling of the urine, that is a urinary incontinence, along with the passage of the normal urine. Why this is happening? Because of the most common site of the opening of the ureter, the ectopic ureter in the females is the vestibule or the vagina. So very, very important points I'm trying to convey over here, right? So the clinical scenarios can be framed to you: continuous dribbling of the urine with the normal passage of the urine as well. What is the diagnosis? Duplication of the ureter in the female. Why this is happening? Because the most common site of the opening of an ectopic ureter in the females is the vestibule or the vagina. Okay, now what about the males? Will the males be incontinent? Please tell me about this. Okay, I want you to answer. Will the males be incontinent? The answer is no. Okay, so if I ask you which of the following sites the ectopic ureter is not going to open in the males. Okay, so I want you guys to answer. Okay, so can you please tell me which of, like, what is the answer where the ectopic ureter is not going to open in the males? The options are prostatic urethra, membranous urethra, let's say prostatic urethra, then bladder neck, then we have a bulbar urethra, and let's say seminal vesicles. Okay, so where will the ectopic ureter not open? I want you guys to answer, okay? So where will prosthetic urethra, bladder neck, bulbar urethra, seminal vesicle? What do you think? What is the answer? I'm waiting for you guys, okay? So I want you to answer. Can you please put your answers? At least a couple of you. First a bit, okay? Bladder neck, okay? Anybody else? Okay, so guys, the answer to this particular question is the bulbar urethra. So what I just told you is that the males are never ever going to be incontinent. So let's kind of revise this particular anatomy over here. This is very, very important, guys, okay? So in the males, what you need to understand, there are two sphincters. One is an internal urinary sphincter, one is an external urinary sphincter, okay? So what do we have? We have an internal urinary sphincter and then we have an external urinary sphincter. Now, in order for the males to be continent, okay, so over here what you have, the bladder, then we have a prostatic urethra, membranous urethra, then we have a bulbar urethra, and then we have a penile urethra. So what you need to understand is, for males to be continent, the ureter always has to open proximal to this particular external sphincter. So it can open to the prostatic urethra, bladder neck, epididymis, seminal vesicle, everything it can open, but it will never open distal to this particular external sphincter, okay? So it is never ever going to open into the bulbar urethra, okay? I hope you have understood this particular point. Prostatic is the most common site, guys, okay? Prostatic urethra is the most common site. Prostatic urethra is the most common site of opening of a, what you call as a ectopic ureter in the males. Okay, so I hope you have understood this particular point. Two things which you cannot forget over here: Wiegert-Mayer law and this particular stuff. Okay, so what is the Wiegert-Mayer law? If at all there is a ureter which is opening, if at all there is a duplication of the ureter which is draining the upper pole of the kidney, that is what is going to open distally and lateral, like medially. So it is always going to be kind of stenotic and everything, and but it's going to go open distally at an ectopic position. The ureter which is draining the lower pole of the ureter, it's going to open proximally and it is going to open laterally, and it is going to be the refluxing. In the females, the history is going to be continuous incontinence with the passage of the urine. The most common site of the opening of the ureter, ectopic ureter in the females, is the vestibule or the vagina. In the males, they are never ever going to be incontinent. The presentation is going to be urinary tract infection, and in the males it is most commonly opening in the prostatic urethra, but the dictum basically says that it is never ever going to open distal to the external sphincter. In other words, it is never ever going to open into the prostatic urethra. I hope you have understood this particular point. Very, very important. Okay, understood? Got it? Right? So please do not forget about these particular stuff, guys. Okay, right? Now, what about the kind of a diagnosis? On the diagnosis, what you're going to have is, you're going to have something which is called as a drooping water lily sign, because the upper pole of the kidney, over a period of time, it's going to become non-functioning, because the ureter which is draining the upper pole of the kidney is stenotic obstructive. So because of the hydronephrosis, the upper pole will become non-functioning. It is going to push the lower pole down, and when you perform an IVP, what is going to happen? Only the lower pole is going to have the dye, and this is what is going to appear like a drooping water lily sign. It is a difference with the water lily sign. So water lily is different, drooping water lily is different. Do not kind of forget confused between the two. Okay, so I hope you have understood this particular point. Okay, right, so treatment is all fine. I can tell you it's fine. So if at all there is, you can perform an heminephrectomy. If at all the upper pole of the kidney has become non-functioning, then heminephrectomy. If the upper pole of the kidney is still functioning, then you can reimplant the ureter. Anything not that important for you guys. That's all fine. Okay, now just look at this. What is this? I am pretty sure that you guys must be aware of this particular image. This is what is a characteristic adder head appearance, or the cobra head appearance, which is basically a ureterocele. Okay, so please do not forget this. What is this? This is what is a ureterocele, adder head appearance, or the cobra head appearance. Okay, now because of the want of time, okay, so this is important. What is this? Cannonball metastasis. Somebody had asked me about the metastasis in the renal cell cancer, right? So what you basically characteristically get is a cannonball metastasis. This was recently asked also, I think, in your RAINS exam or something, right? Exam or something. So cannonball metastasis. Okay, I hope you have understood this point. Okay, now because of the want of time, what I'll cover is that I'll try to cover a couple of more topics when I kind of revise the GIT, at least understand the testes and everything I'll try to cover. But for now, what I'm going to cover is, I'm going to cover the urological trauma, because this is very, very important. Okay, so I'll just cover the urological trauma for today. So what you need to understand in the urological trauma, so I'll not be covering the kidney and the ureteric trauma, that's all fine. But the important thing, and this is very, 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 very important, I've seen, and I'll spend some time over here because this is very, very important topic. And I've seen so many kind of students committing a lot of mistakes in the clinical scenarios based on this particular bladder injury and the urethral injury. Okay, so we'll cover that. Okay, now what you need to understand is, okay, first of all, let's kind of test you. I'll just give you a couple of questions and then I want you to answer. Okay, so and please answer a bit fast. Okay, so let's assume that there is a patient who has come to you after the road traffic accident. The patient is okay, so there's a patient who has come to you after the road traffic accident. The patient, the accident basically happened yesterday night, and the patient has come to you today night at 9 p.m. Okay, so the yesterday night the accident happened. Okay, now the patient is basically uh, you go to the patient and you basically ask the patient that, okay, do you have any problem, do you want to pass urine or something like that? Patient says, no, I don't want to pass urine at this point of time. Okay, have you passed urine in last 24 hours? The patient says, no, I have not passed urine in last 24 hours. Then you basically examine the patient and you basically get that, you know what, there's a blood at the urethra, there's some blood which is basically present at the urethra, that's all fine. And when you perform an x-ray, on the x-ray there is a pelvic fracture which is kind of present over here. Okay, so what is the diagnosis of this particular patient? Can you please tell me what is the diagnosis of this particular patient? What is going to be the diagnosis of this particular patient? Extraperitoneal bladder rupture, intraperitoneal bladder rupture, anterior injury, posterior injury. A, B, C, D. Okay, extraperitoneal bladder, you can just write A, B, C, D. Extraperitoneal bladder rupture, intraperitoneal bladder rupture, anterior injury or the posterior injury. What do you think? What is going to be the answer? Okay, so okay, right. Okay, so those of you who have written urethral injury, okay, so those of you have said urethral injury. Why did you say the urethral injury? You said it because I said that there is a blood at the meatus. Now, blood at meatus doesn't mean any damn thing. Okay, so yes, the correct explanation is recondite. Okay, so no urge to urinate, it is going to be the bladder trauma. Now, what kind of a bladder trauma is it? Is it like an extraperitoneal bladder rupture or an intraperitoneal bladder rupture? Okay, so it is an extraperitoneal bladder rupture. Okay, so let's kind of talk about all these things. Okay, right. RTA, blood at the meatus. So that's what I'm trying to tell you, Satya, right? Blood at meatus means nothing. I deliberately gave it to you because of some, because I wanted to kind of confuse you, okay? But you have to look at the entire clinical scenario in one go. So every time there is a blood at meatus, you will say that it's a urethral injury, is it? So somebody kind of came and kind of pushed 4 and 5 ml of the blood into the urethra. Or are you understanding? It can happen because of n number of reasons, right? Blood at the meatus. Blood at meatus means absolutely nothing. I hope you have understood this particular point. You have to look at the clinical scenario in kind of a totality. Okay, so let's kind of talk about this. Okay, so okay, now let's start with the bladder rupture. So what you need to understand is that the bladder is basically an extraperitoneal organ, right? So what you need to understand that there's a peritoneal fold which is covering the bladder. So the bladder can get ruptured over here. It means that the bladder can rupture over here, which is basically an extraperitoneal bladder rupture, or the bladder can get ruptured over here, which is basically an intraperitoneal bladder rupture. Okay, I hope you have understood. Everybody is okay till now. Now, okay, so why do you have an urge to pass urine? Okay, we do pass urine, right? Why do we have an urge to pass urine? Because our bladder fills up, right? Our bladder fills up, it basically sends a signal to the brain, and our brain says that, you know what, the bladder is filled, go and pass the urine, right? Now, in these particular patients, what is going to happen? If at all there is a bladder rupture, forget about whether it is an extraperitoneal or intraperitoneal. What is going to happen? That there's going to be no urge to pass urine because bladder is never filled up. Because bladder is never filled up, there's no stimulation of the brain, and the brain is never going to say that, you know what, go and pass the urine. No urge to pass urine. So I hope you have understood. Absolutely bang on what the content said. No urge to pass urine, it's a bladder trauma. So it doesn't matter whether it is an extraperitoneal or an intraperitoneal bladder rupture. In both these particular scenarios, there's going to be no urge to pass urine. I hope you have understood this particular point. No urge to pass urine, bladder trauma. Now we'll talk about whether it is an extraperitoneal, intraperitoneal, how do we decide it? We'll talk about this. But I hope you have understood till now, right? We'll talk about the urethral trauma, just give me a minute, okay? Right. Now, when we talk about the bladder rupture, as I told you, it can be an extraperitoneal or the intraperitoneal. Now, in the extraperitoneal, what you need to understand is that it is usually associated with the pelvic fracture. So, in the history, if at all they give you road traffic accident, no urge to pass urine, pelvic fracture present, then it is extraperitoneal bladder rupture. Okay, these three things. Okay, now what you need to understand is that you tell me, in the extraperitoneal bladder rupture, are you going to have a deep perineal hematoma or a superficial perineal hematoma? So what are you basically going to have you're going to have a deep perineal hematoma. So what is this deep perineal space? This is what is the bladder, prostatic urethra, membranous urethra, bulbar urethra, penile urethra, right? And what do we have over here? This is what is a urogenital diaphragm. So whatever the part above this particular urogenital diaphragm, this is what is a deep perineal space. Okay, what is this? This is what is a deep perineal space. So if at all there is an extraperitoneal bladder rupture, what are you basically going to have? You're going to have a deep perineal hematoma. So as you can see over here, in the extraperitoneal bladder rupture, pelvic fracture associated with the, okay, it may be associated with the proximal or the posterior urethral injury. It's okay. You can just remember it, but not that important. It will lead to a deep perineal hematoma. I hope you have understood this particular point. Okay. So I'll just jot down all the things. Road traffic accident, no urge to pass urine, or as I told you, I did not directly tell you that there is no urge to pass urine. I told you that last 24 hours the patient has not passed urine and the patient doesn't want to pass urine. Now, has it ever happened with you that you have not passed urine for 24 hours? Obviously not, right? Are you understanding? So we usually pass urine after every 3, 4, 5 hours. So that is what you need to understand over here. In the history, they might not directly tell you that there is no urge to pass urine, but in the scenario, they are going to tell you in one way or the other. I hope you have understood. So road traffic accident, no urge to pass urine, pelvic fracture, deep perineal hematoma, extraperitoneal bladder rupture. Understood? Now, let's talk about the intraperitoneal bladder rupture. How will the intraperitoneal bladder rupture? What is the mechanism of injury? So let's assume that there is an over-distended bladder and somebody basically comes and punches the patient in the suprapubic region. Okay, so if at all there is an over-distended bladder, what is going to happen? The fold of the peritoneum, which is going to cover the bladder, is going to increase. And now, if at all there is a blunt trauma, that is what is going to have what you call as a intraperitoneal bladder rupture. So once in your exam, how they had kind of given you that there is a patient who was drinking a lot whiskey, whatever the patient was drinking a lot, and then the patient basically went to the washroom, and in the washroom the patient fell down. Are you understanding? So what they were trying to tell you is that whatever the alcohol the patient was drinking, it acted as like a diuretic. The patient's bladder was over-distended, patient went to the washroom, patient fell down, a blunt trauma, it will lead to intraperitoneal bladder rupture. Understood? So that is one of the mechanisms. Another is the penetrating trauma. If at all they say that there is a penetrating trauma with the bladder rupture, 99% is an intraperitoneal bladder rupture, because obviously penetrating trauma will go through the abdomen, right? That's what you need to understand. Now, here, it is not associated with the urethral injury. Forget about this, okay? It's just forget about this. It's okay, even if you don't remember. It is going to lead to peritonitis, okay? So intraperitoneal bladder rupture, what is going to happen? The urine is going to go into the peritoneal cavity. The patients are going to have peritonitis. Okay, obviously patients will develop peritonitis. Now let's talk about the management. If at all there is an extraperitoneal bladder rupture, how are you going to manage the patients? So you are going to pass a Foley's catheter. Once you pass a Foley's catheter, what is going to happen? The bladder is going to get decompressed. Now assume that there is a bladder rupture, extraperitoneal bladder rupture, and if at all you have decompressed this particular bladder, what is going to happen? The edges of these particular bladder are going to come closer to each other, and now by the normal process of the healing, the bladder can get healed by itself. So you put a Foley's catheter, you keep it for around, let's say, 10 to 14 days, and after that you kind of do a cystogram to see whether the bladder has got repaired or not. Are you understanding my point? So conservative management, Foley's catheterization. What did we talk about in the trauma? That any trauma, if at all there is a patient who is having a signs of peritonitis. What are the signs of peritonitis? Rigidity and the guarding. So if at all after the trauma the patient is having the signs of peritonitis, that is rigidity and the guarding, like what we basically do is we have to kind of perform an exploratory laparotomy. Are you understanding my point? So we have to perform an exploratory laparotomy. So in the intraperitoneal bladder rupture, you definitely have to perform an exploratory laparotomy. I hope you have understood this particular point, guys. So I'll just kind of tell you both the scenarios again. Patients with road traffic accident, no urge to pass urine, X-ray shows pelvic fracture. On abdomen palpation, it's absolutely normal. There's a deep perineal hematoma, usually they are not going to give. What is the diagnosis? Extraperitoneal bladder rupture. Another scenario, road traffic accident, no urge to pass urine. The patient on abdominal palpation, there is a rigidity in the guarding, intraperitoneal bladder rupture. I hope you are able to understand this particular thing, right? Okay. Now let's talk about the urethral injury. Now in the urethral injury, what the patients are going to tell you, right? So the one thing which you will have to kind of read in the urethral injury is that there is an intense desire to pass urine, but the patient is not able to pass urine. So when you go to the patient is going to say, you know what, I really want to pass urine, but I'm not able to pass urine. And here, when you palpate, usually you might have a palpable bladder as well. But even if they have not given you the palpable bladder, that's all fine. But if at all, they have to give these particular words that there is an intense desire to pass urine, but the patient is not able to pass urine. No doubt, the blood at the meatus is usually present in the urethral injury. I'm not denying this particular fact, but just with the blood at the meatus, you're making the diagnosis of the urethral injury. It's absolutely bullshit. It should not be done. I hope you have understood this particular point, guys. Okay. Understood? So intense desire to pass urine, but the patient is not able to pass urine. That is what is going to be the history, right? It doesn't matter whether it is an anterior or the posterior urethral injury. Now the next thing they ask you is that, okay, I give you a scenario that there is a patient who is basically having, after the road traffic accident, the patient is coming to you. Now the patient is basically having an intense desire to pass urine, but the patient is not able to pass urine. Okay, what is the next step? What you're going to do? I'll give you the options. The options are suprapubic catheterization. Okay, the second option is Foley's catheterization. The third option is retrograde urethrogram. The fourth option is CT scan. What are you going to do? I'll repeat the options. A is suprapubic catheterization. B is Foley's catheterization. Third is retrograde urethrogram. Fourth is basically, what did I say? CT scan. Yeah. So please guys, everybody answer. Everybody answer. Okay, so yes, the answer over here is retrograde urethrogram. Okay, I hope you're able to understand over here. It's a retrograde urethrogram. See, what you need to understand. Okay, right. No recorded. Okay, so please try to understand over here. Okay, so first of all, suprapubic catheterization is always the wrong answer. Why it is a wrong answer? Because till now you have not diagnosed the patients to be having a what you call as a urethral injury. Okay, just if at all you have a palpable bladder and the patient is basically having intense desire to pass urine, patient is not able to pass urine, it doesn't mean that the urethral injury is there. There is a chance that the patients might be having whatever the sphincters have become very tight, or there is a sphincter edema or something like that. I understand my point. You have not yet diagnosed. So suprapubic catheterization is never an answer. Now the two schools of thoughts are, the one school of thought basically says that a single gentle attempt of the catheterization can be tried by the most senior person present in that particular trauma center. You understand my point? So if at all they say these particular lines, a single gentle attempt of the catheterization by the most senior person present in the kind of a trauma center, you can do that. That's fine. But this has been kind of revolted back. Why? Because there is a chance that the partial injury might get converted into the complete injury. Okay, so if they simply say Foley's catheterization, no, not really. That's not the kind of answer. I hope you have understood, right? So what is the next kind of a step? You have to perform a retrograde urethrogram, RGU. Because if you perform an RGU, that is what is going to tell you, if at all there is a dye which is leaking out from the urethra, you have diagnosed that the patient is having a urethral injury. We will talk about anterior, posterior and everything, but you have diagnosed the patient as a urethral injury. But if at all there is no leak from the urethra, it means that there is probably a sphincter spasm. So now you can pass in a Foley's catheter, you can keep it for let's say 3 to 5 days and then you can remove it later. Everybody have understood this point? Suprapubic catheter, absolutely wrong answer. Single gentle attempt of the Foley's catheter with done by the most senior kind of doctor present in the trauma center, still acceptable, that's fine. But simply if all they say Foley's catheterization, never an answer. Even the single gentle attempt of the catheterization is not that well accepted. Idealistically, you should do an RGU in order to diagnose a urethral injury first. Okay, I hope you have understood this particular point. Okay, right? Everybody have understood this particular point? Very, very important. I've seen this being asked so many times and then you guys screw it up. Okay, but I hope you have understood this point. Okay, so what is this? This is what is your, what is this? What is the diagnosis? It is an extraperitoneal bladder rupture. Okay, so I'll talk about the urethral injury. Just the image came, that's why I'm covering over here. So what is this? The dye coming out from the bladder. This is an extraperitoneal bladder rupture. What is this? This is what is an intraperitoneal bladder rupture. Dye is basically going into the peritoneal cavity. So that is what is an what you call as a intraperitoneal bladder rupture. Okay. Right. Now let's talk about the posterior and the anterior urethral injury. Now, what is the risk, like what else they are going to give you in the history? So in the posterior urethral injury, there's going to be associated pelvic fracture. So in the posterior urethral injury, you have an associated pelvic fracture. Now here, again, you're going to have a deep perineal hematoma. We have discussed this particular stuff, right? Okay, so we'll go back to that particular image. So I hope you're able to understand, if at all there is a posterior urethral injury, the patient is going to have a deep perineal hematoma. Understood? Right? Okay, right. Now, another important thing is when you do a digital rectal examination, sometimes the prostate is not palpable. Why it's not palpable? Because the prostate is basically lifted up. So what is it called as? It is called as a high riding prostate. So either the prostate is not palpable or the what you call as it, there is a high riding prostate. What is this called as? This is what is referred to as the Vermeuten's sign. Vermeuten's sign. Okay, so now I'll tell you the clinical scenario. Road traffic accident, the patient has an intense desire to pass urine, but the patient is not able to pass urine. On the X-ray, there is a pelvic fracture. The patient is basically having a deep perineal hematoma. On digital rectal examination, the prostate is not palpable or the prostate is high riding. What is the diagnosis? It is a posterior urethral injury. I hope you are able to understand this particular point. Okay, so what is this? This is what is the scenario of a posterior urethral injury. Now talking about the anterior urethral injury. In the anterior urethral injury, the mechanism of injury is a straddle injury. So what is this particular straddle injury? That the patient was walking and the patient basically had an injury with what you call as a manhole. Okay, so the manhole cover, it basically came and hit the patients in the crotch. Or let's say the you would have seen the bicycles with the whatever the iron rod, right? I mean, like the horizontal rod or something like that. And let's say if at all the patient slips from that particular paddle or something like that, and the patient basically falls down, then what's going to happen? The poor urethra is going to get crushed between that particular iron rod and the pubic symphysis. Are you understand my point? So this is what is referred to as your straddle injury. Straddle injury. Now, this is what is going to lead to a superficial perineal hematoma. Okay, so here the anterior urethral injury, if at all that happens, what is going to happen? There's going to be a superficial perineal hematoma. This is also referred to as a butterfly shaped hematoma. So when you basically look at that particular kind of a pelvic examination, what are you going to have? Superficial perineal hematoma or a butterfly shaped hematoma. Butterfly shaped hematoma, that is what you need to understand. On digital rectal examination, prostate will be absolutely normal. Okay, prostate is not going to be high riding. So why is the prostate high riding in the posterior urethral injury? Because the membranous and the bulbar urethra have got separated, and because of this, now the prostate is free. Now the prostate can go up. But if at all there is an injury to the bulbar urethra, the prostate is still adhered to whatever the urogenital diaphragm. So prostate is not going to go up. I hope you have understood this particular point. So I'll quickly kind of summarize the clinical scenario. Road traffic accident, intense desire to pass urine, pelvic fracture, deep perineal hematoma. On digital rectal examination, the prostate is high riding, prostate is not palpable, posterior urethral injury. Road traffic accident, intense desire to pass urine, patient not able to pass urine. On physical examination, there is a superficial perineal, whatever the butterfly shaped hematoma is there, and on digital rectal examination, the diagnosis is anterior urethral injury. Now, it doesn't matter whether it is an anterior or the posterior urethral injury. Once you have diagnosed that, now you're basically going to put a suprapubic catheter and you're going to send the patients home. You're going to call the patients not after 6 weeks, rather, let's say after 3 months or something like that. And then what you're going to do, you're going to ask the patients to, you will kind of obstruct that particular kind of SPC, and then you're going to ask the patients to pass urine. If at all the patient is able to pass urine, that's great. You remove the SPC. You can also perform a retrograde ureterogram to see whether there is any development of a stricture or not. And if at all there is a development of the stricture, then you can repair it. But all this, what I've talked about the management, it is all like not that relevant for you at this point of time. For you, what is relevant is the 4 clinical scenarios: diagnosing the extraorbital bladder rupture, intraorbital bladder rupture, posterior urethral injury, anterior urethral injury, and what are you going to do next if at all you have a patient with this, like a road traffic accident, intense desire to pass urine, palpable bladder till the umbilicus. It's not suprapubic catheterization. What you have to do is a retrograde ureterogram. Okay, so this is all about the urological trauma which I wish to kind of cover with you guys. I hope this has helped you. These particular 4-5 clinical scenarios are absolutely must know. I hope you have understood this particular point, guys. Okay, now because of the want of time, what I'll do is I'll just stop at this point of time, and then what we'll do is we'll cover probably a couple of topics, one more. I'll schedule the session probably tomorrow or at the max day after tomorrow. I'll cover the few topics of the GIT, and then let's say a couple of more topics of the urology I'll cover in that particular session. Okay, right? So yeah, I hope you gain something out of this particular section. Thank you for joining up. Lastly, I'll just kind of tell you once more that this is what is a QR code. If you wish to connect with me on WhatsApp, you can just scan this and you can kind of connect with me. And this is what is like a YouTube channel. If you wish, you can kind of consider subscribing it. I'll be kind of being active on this, and this is what is Instagram. You can connect with me on the Instagram. I'll be more active on Instagram pretty soon. Okay, now so Satisha, yeah, tomorrow or maybe the day after tomorrow I will have the last session, obviously, because 11th again you have the exam, right? So yeah, I'll maybe share a small recorded video with you, or I don't know, I'll just do that. I personally feel that there's so many videos, so many opinions which are going to, okay, I'll do that. I'll share, let's say 5 to 10, 15 minutes, probably a small recorded video with you guys, just to kind of tell you what to do, what not to do, or just my 2 cents before your final day, before your exam or something like that. And I think that should be kind of enough. Okay, I'll definitely send the PDF today, like now itself, within 15-20 minutes. I'll send you the PDF today night. I'll definitely send you the PDF of this, and previous day sessions or something. Okay. Thank you so much, guys. Thank you so much for joining with me. Good night and see you soon. I'll update you. Tomorrow or at the max day after tomorrow, we'll have the session and we'll cover the GIT and few more topics of the urology, whatever we are there. Okay. Thank you. Bye. See you. Good night. Take care. Bye.